have the slides that the speaker view.
It's not working somehow.
Okay.
I don't know why, but it's not working.
Anyway, but the screen is visible to all.
It to all, no? So it's all right. Okay.
Yes. Okay.
Okay. And thanks to Foxy and Dr. Shanta Kumari and Ajay and all the other Foxy members who have helped us to make these slides. And it took quite a long time. Thank you once again. So gender-based violence is the most pervasive yet least visible human rights violation in the world. You all know that. And to put your response in that, can you put your response now? What forms of gender-based violence are experienced as women? In the chat box. You can put your answers in the chat box. And where can women and girls experience gender-based violence? Which age groups may experience gender-based violence? So, did you put all your answers? Yeah, I can see. Basic violence. Okay, that's good. We'll go to the next slide anyway. So, what do we understand by violence against women? So, violence against women means any act of gender-based violence that results in or is likely to result in physical, sexual, or psychological harm or suffering to women, including threats of such act, coercion, or arbitrary deprivation of liberty, whether occurring in public or in private life. So violence against women encompasses, but not be limited to physical, sexual, or psychological violence. It can be within the family, community, or in the state level. So the types are physical, psychological, and sexual violence. So what comprises physical violence is kicking, biting, slapping, beating. We all see this. We all see the injuries in our OPDs also sometimes. But psychological violence is very silent. Preventing a woman from seeing family and friends. This is also a type of violence. Belittlement or humiliation. Economic restrictions. Violence or threats against cherished objects. Other forms of controlling behaviors. All these come under violence. So sexual violence, we all know sexual violence, forced sex using physical force, threats, intimidation, forced participation in degrading sexual acts, denial of right to use contraceptives or measures to protect against sexually transmitted diseases. So when we see the prevalence, it's actually 30% globe across the globe. So we can see this map here, the globe map, so that it is almost see 36% in Southern Africa, 37.7% in Southeast Asia. So intimate partner prevalence, violence prevalence is physical and or sexual partner in their lifetime. In South Asia is the statistics is here, and in India it's about 30%, 28.8%. So it is only the tip of the iceberg. So GBVP is underreported. So 40% of women experienced gender-based violence previously disclosed to someone, some family or someone, but only 7% reported to a formal source like a police or legally or anything. So I think it's India is about 2%, and across Asia it's about 14%. The cycle of abuse can be in all stages of a woman, like from pre-birth to infancy, girlhood, and adolescence. So pre-birth, it's sex-selective abortions. We all know effects of battering on pregnancy and childbirth. Then it can be female infanticide, physical, sexual, psychological abuse. Then when it comes to girlhood, it can be child marriages, female genital mutilation, physical, sexual, and psychological abuse, incest, child prostitution, and pornography. So when it comes to an older child, that is adolescence, trafficking, honor killings, partner violence, marital rape, dowry abuse, dowries, murders, abuse of women with disabilities, rape, sexual harassment, forced prostitution, all these are there. So the other things are forced pregnancy, acid throwing and date rape, economically coerced sex, incest, and sexual abuse in workplace. So 20% of women experience child sexual abuse. And 50% of child marriages occur in South Asia. And 125 million women in 29 countries in Africa and Middle East experience female gender violence. So about 2,000 women in Pakistan killed in the name of honor between 2003 and 2007. 11.4 million women trafficked globally. And 30% experienced intimate partner violence. And 7% sexually assaulted by someone or the other partner. So health impacts of gender-based violence on individuals is physical or reproductive. So physical, we have acute and chronic. In acute, it's injury, shock, disease, infection, weight loss or gain, regressive behaviors, or not eating or eating all the time. So chronic is disability, chronic pain, gastrointestinal disorders, eating disorders, sleep disorders, and chronic fatigue. When it comes to reproductive, it's miscarriages, unwanted pregnancies, unsafe abortions, STIs including HIV, menstrual disorders, pregnancy complications, and gynecological disorders. So effects beyond the individual survivors are effects on children. I mean, not only the victim, but beyond that is effects on children who experience abuse, are higher rates of infant mortality. I'm so sorry. Infant mortality, behavior problems, anxiety, depression, and attempted suicide of those children, poor school performance, physical injury or health complaints, experiencing or perpetrating violence as adults. So they think they can do it as adults, so it goes on. So effects on families is fractured family relationships, safe care if abuse happened in the home, housing instability, co-occurring violence, poorer collective health and coping. Effects on community and society are costs of services incurred by victim and families on health, socially, and for justice. Loss of education and potential development and contributions by child as they become an adult. Perpetuation of violence in community and higher crime rates, burden on safety and justice sectors. Where and how do violence and HIV/AIDS intersect? So how they intersect is direct transmission through sexual violence, type of the sexual violence, presence of other STIs, and degree of trauma. Or it can be indirect transmission through sexual risk-taking. Violence is linked to increased risk-taking, multiple partners, non-primary partners. Or it can be through inability to negotiate condom use. Women find it difficult to suggest or insist on condom use in face of or threat of violence. So what is the, this thing is physical trauma and psychological trauma and fear and control. So how is go to physical is, we know all these musculoskeletal, soft tissue, all these physical injuries. Then psychological can be in mental, it can affect the mental health, anxiety, depression, eating disorders, and they can go up to substance abuse also, alcohol and other drugs or tobacco, one of these drugs. And it can lead to non-communicable diseases like cardiovascular disease, hypertension, etc. Or it can be psychosomatic like irritable bowel syndrome, chronic pain, chronic pelvic pain, etc. Or fear of control is limited sexual and reproductive control and lack of contraception. This is because of the lack of contraception and unsafe sex. Or health care, it may be difficult for health care seeking also. Lack of autonomy, difficulty seeking care and other services. And perinatal maternal health also will affect low birth weights, prematurity, pregnancy loss, And sexual and reproductive health, unwanted pregnancies, abortion, all these also will be affected. So 42% of women who have experienced physical and sexual violence at the hands of a partner have experienced injuries as a result. So mental health twice as likely as they experience depression. So which we don't see most of the time. The family also neglects or they oversee it. Almost twice as likely as have alcohol use disorders. 16% more likely to have low birth weight babies. Twice as likely to have an abortion. 15 times more likely to acquire HIV and 1.5 times more likely to contract syphilis infection, chlamydia or gonorrhea. And 38% of all murders of women globally were reported as being committed by their intimate partners. And 4.5 times as likely to attempt suicide. So it's a small quiz. I think you can all either put in the chat box or just think for yourself. So the statement being intimate partner violence is more prevalent among poor women and girls. Is it a myth or a fact? So the answer is it's a myth. Studies show that gender-based violence can happen among people of all socioeconomic, educational, and racial backgrounds. Violence may affect our peers, colleagues, and friends also. The next question being, in some instances, especially when it is not severe, beating by a husband can be an effective form of discipline if the wife is acting inappropriately. Is it a myth or a fact?
Myth.
It's a myth.
It's a myth.
Gender-based violence is a serious human rights, health, and development issue impacting survivors, their families, and the health and development of the entire communities. The third one being majority of sexual violence against women and girls is perpetrated by strangers. Is it true? It's a myth. Studies consistently show that most women who experience sexual violence are abused by people they know. Often the perpetrators are those they trust and love. Globally, women's homicides are 6 times more likely than men's to be committed by an intimate partner. The fifth question being, is it safer for a woman to leave a relationship with an abuser than to stay?
Yes. Yes.
Yes.
Safer.
I know, even I thought, but this says violence often continues and may even increase after a woman leaves a partner. In fact, a woman's risk of being murdered is greatest immediately after separation. And this is what I think the statistics have shown, though emotionally we all feel it is true that they leave the relationship, and I think psychologically they'll be better. I don't know, it's an individual opinion, but the statistics shows this. So gender-based violence is a serious human rights, health, and development issue impacting survivors, their families, and the health and development of the entire communities. So I hope all of you have done the pre-test, and I request you to do the post-test and feedback to get your certificates. Thank you.
Thank you. Thank you so much, Vindhya. I think the quiz time was really, really interesting. Yeah, and brought in a lot of yes and no's and falses over there, which is very, very interesting.
I know, but the last question was a little tricky.
Yeah.
Many of us thought it is
the last question we learned in the UNICEF GBB module.
Yes.
So it is tricky to tell.
Yeah, it is tricky, but I think most of us feel it is better to leave the relationship. At least psychologically, they will be better.
Yeah, but with safety nets and all. Yeah.
Safety.
Yeah. But yes, psychological health will definitely improve.
Protective family support. I think at least it is better for our country and our girls.
Yeah. And the UNICEF is more of the global statistics, and to that extent, It may not be completely true in our case, but it's a mix and match, and therefore we have to move forward with that accordingly. How to approach a woman facing violence? Raki, you're the best person to walk us through that entire session. Over to you.
Yes, thank you. After listening to the overview, let's move on ahead and just to know about how to approach a woman who's facing a lot of violence. We need to understand, and we need to why do survivors not seek help? That is the basic thing what we need to understand, that at times they just keep quiet. The victim could be blaming attitudes of the providers. There could be fear of shame or stigma, which could be associated. Fear of no confidentiality can be there. Inappropriate services or services that are not useful or prioritized by the survivor. Perceived impunity of perpetrators, or any other reason. If you find, then you please kindly put in the chat box so that we are more learned at the end. And ideally, who can play the help of the survivor, and how can we help? The individual is a center point who is having a lot of problems. So it could be the healthcare provider where she would be looking at, and the healthcare provider is the first approach where she can confidently come and talk. And then comes the family, the friends, which is the other angle to it. Otherwise, she can look forward to the community-based, the NGOs, and all those aspects where she can look forward for the help. Coming down to the role of family, friends in the community, recovery from violence, dependent on extent of support received from the loved ones. Health professionals engage with family and discuss ways of promoting survivors' well-being. It should be discussed with all the caregivers that survivors should not be held responsible for the assault. We should be making the survivor understand that you are not responsible for it. In the case of child sexual abuse, the parent may experience anger, confusion, guilt, self-blame that needs to be tackled. Reiterate that it is the perpetrators who misuse their position for this gender-based violence. We as healthcare providers, we should be, all the women are likely to seek health services at some point in their lives. Healthcare providers are often trusted by women and serve as a role model in the community. Violence is an underlying cause of injury and ill health. We should be creating an enigmatic atmosphere and establishing trust with our patients. Speak to the survivor in the private space. Recognize her courage in reaching you, as they have overcome several barriers. Recognize the dilemma faced by the survivor in reporting violence. Do not label non-reporting of the survivor to police as a false case. Assure the survivor that the treatment will not be compromised. Inform the survivor of available resources, legal rights, so that they can take an informed decision. The health professionals should prepare the survivor for an internal examination. We have to have the confidence, build the confidence of the survivor, and explain the various stages of examination, communicate the rationale for the referral for the X-ray, ultrasound, the age estimation, all the tests, whatever we are requiring from the survivor that we are going to do. Role of the healthcare provider in addressing the survivor's emotions. Recognize the survivor and may present varied emotions. Encourage the survivor to express her feelings. Encourage the survivor to seek crisis counseling. Assess for suicidal ideation. Make a safety assessment and safety plan. Involve family and friends in healing process of the survivor. Ideally, while talking or discussing with the survivor, what are the leading questions what we would be putting forward? It could be like, Take your time, share only what you would like to share. I can imagine that must have been really hard. It takes a tremendous amount of strength to share what has happened with you. Take your own time. How do you think we can help you? You are not alone. We are there with you. The practical approach is what we are going to follow would be the solar. Solar is sitting position, O for the open posture, L for the leaning forward, I is maintain a eye contact with the survivor, R is just be relaxed and make her comfortable. Supporting the survivor using the life's approach. Life's approach is L stands for listen, inquire, validate, enhance safety and support. Coming now to this listening part. The verbal or the non-verbal means show the support of communication to understand. Ask the questions which are open-ended, focused, and not the close-ended questions. Use good body language and posture, and the eye contact needs to be maintained. Avoid any leading questions, compounded questions. Listen to the survivor, giving her undivided attention. Truly hearing her concerns with care and respect. Ideally, the do's and the don'ts for the listening part would be, how do you act? It would be patient and calm. Let the client tell her story at her own pace. Don't pressure her to tell her story. Let her know you are listening through verbal and non-verbal clues. For example, nod your head, say, Maintain a gentle and appropriate eye contact with the patient. Do not look at your watch, speak too rapidly, don't answer the telephone, look at the computer or anywhere else, or start writing down. Your attitude would matter. Acknowledge how she is feeling and do not judge what she has not done or how she is feeling. Don't say you shouldn't feel that way or you should feel lucky you survived. What we should be able to tell these survivors would be, give her the opportunity to say that she wants. Ask her, how can we help you? Encourage her to keep talking if she wishes. Ask, would you like to tell anything else more? Do not assume that you know what is the best for her. Don't interrupt. Wait until she finishes before asking the questions. Do allow her for silence. Give her time to think. Stay focused on her experience and offering support. Acknowledge what she wants and respect her wishes. Don't try to finish her thoughts for her. Don't tell her about someone else's story or talk about your own troubles. Don't think and act if you must solve her problems for her. I stands for inquire. We need to inquire, and that is the need for the concern. How do we go ahead? Phrase your questions as an invitation to speak. Ask open-ended questions instead of yes or no questions. Check your understanding by restating what he or she says. Reflect back to the client the feelings they express. Explore as needed. Ask for clarification if you don't understand. Help her to identify and express her needs and concerns. Sum up what she has expressed. Ideally, what we need to tell during the inquiry details would be, what would you like to talk about? How do you feel about that? You mentioned that you feel very frustrated. It sounds as if you are feeling angry about that. Could you tell me more about that? Can you explain that again, please? Is there anything that you need or are concerned about? You seems to be saying that. We stands in that life's approach, we stands to validate. Validate does not mean to try and verify the survivor's story. For example, through interviewing the alleged perpetrator or witness. This is not safe, appropriate, ethical, or recommended. Show that you are concerned, you understand and believe them. It's not your fault. You are not to be blamed. You did the most important thing you could do in that moment. You survived. Help is available. Say this only if it is true. No one deserves to be hit by their partner. You are not alone. Unfortunately, many others face this problem. What happened has no justification or excuse. Your life, your health, you are of value. Everybody deserves to feel safe at home. I am worried that this may be affecting your health. It's okay to talk. Empathy versus sympathy. We need to understand and create the boundaries. Sympathy is a personal emotional identification with the survivor's experience and implies that the service provider feels sorry for the survivor. It is the emotional state that leaves the service provider, vulnerable to over involvement and can take the power away from the survivor. It is identifying with the survivor's experience through your own shoes. Empathy implies intellectually or the personal understanding and realistic professional distance. It involves compassion and objective and leaves room for empowerment of the survivor. It is an attempt to put oneself in the survivor's shoes. Dealing with emergency situations during your approach of the lives. Challenging issues while dealing with the survivor who is immediate at danger. If the survivor tells you that the abuser has threatened to harm them, what should you do? Put your thoughts in the chat box, please. As a provider, we are not you. It is not your sole responsibility to take care of it. A few ideas would be like ask concrete questions about safety risk, but only when there is privacy. Ask the survivor, has a safety plan in place in case she needs to flee. Discuss potential strategies for being able to leave her situation safely. Provide a referral to the gender-based violence expert agency for additional help if possible. Challenging issues would be like be able to recognize signs of depression and suicidal risk. Do not be afraid to ask, are you having thoughts of suicide? If the answer is yes, take it seriously. Do not leave the suicidal survivor alone if there is immediate danger. Always consult a superior about how to refer or manage a suicidal survivor. Never make a decision on your own. This is for your own safety and well-being. Provide a referral to a gender-based violence expert agency for additional help if possible. Ignoring violence can do more harm. We as a service provider our behaviors should be like blames or disrespect of the woman or girls. The consequences would be inflicts additional emotional stress or the trauma. Doesn't recognize GBV behind chronic or recurring conditions. A woman receives inappropriate or inadequate medical care. Fails to provide post-rape care or address a GBV in family planning or the STI or HIV care. Unwanted pregnancies, STIs, HIV, unsafe abortions, and more violence would be there as a consequence. Breach the privacy or confidentiality. Partners or the family members become violent after overhearing the information. Ignoring the signs of fear or emotional distress, the woman is later injured, killed, or commits suicide, where we need to take care. The doctor helped me feels better by saying that I don't deserve this treatment, and he helped me to make a plan to leave the house the next time my husband became violent. This should be the answer by the survivor, and the survivor should have that much amount of confidence in us. Warm referral practices help the woman reach the further care. The mental health and the support system linkage and the helplines are always available. It's a joint effort by the healthcare providers, the psychosocial support, the legal justice, and the security. All of us should be working hand in hand and helping these GBV survivors to have a respectful, healthy life. Registration of the pre and the post test is mandatory for all of us. Kindly do fill in the feedbacks and because that is going to be helping us for the certificate and award the participants on the course of the attendance, and submission of the post test is required. Do remember to give the feedback also.
Thank you, Raki, for doing this and so elaborately. And it's, I think, even it's a little heavy on us psychologically, all of us, and going back to all the stories which we have experienced also. And so the thing is that not that we all don't know how to see these patients, but only like, you know, to be very calm and then sympathetic to the patient. I like your slide of sympathy and empathy. It was very good. So, and then just to how to approach it, refresh ourselves, how to approach these patients and how to guide them, and then go further in life for them. And if we have any contacts of our NGOs or you said the centers, we can refer them to them.
Yeah.
Now, any questions, any discussions?
Lot of discussion happening in chat, ma'am. We are answering in the chat itself.
I know I saw, but counseling and all that. Shall we have a discussion at the end? Do you want to go ahead, Kiran?
Yes, ma'am. I'll go ahead.
So now Kiran will start off with the effects of wow on pregnancy and newborn. And that's a very passionate subject for Kiran. She did a study also on it. So she'll be very emotional on this subject. Welcome, Kiran.
Thank you, ma'am. Actually, we did spend a lot of time in curating this whole module. So,
This whole module has been prepared passionately by all of us under the guidance of the President Foxy, Dr. Shanta.
yes, Raki. And
Kiran was also there, the right hand, and then apart from that, Dr. Ajay was almost the team leader, guiding us all through.
at the back of us.
Yeah.
Absolutely.
Yes.
Absolutely.
All the hard work each one does, and I get the credit. Thank you very much.
No, sir. Without you, we couldn't have done. You are the leader.
Yeah, it was you who were behind all of us, and Kiran and Madam and everybody. It was
Yes, absolutely.
You were the man behind us.
Absolutely. Yes.
We can change the narrative from a gender-based thing, you know. Behind every successful group of women, there's a man. Yeah.
yeah.
Right,
Okay,
right.
Kiran, carry on. Yeah.
Yes. So with the first two presentations, I think it has been made very clear to what we are trying to do is establish the link between the violence and women's health. Basically, as the obstetricians and gynecologists and women healthcare specialists, so our concern is with the overall health of the women we treat. So how violence interplays and how we can, as healthcare workers, at an important juncture of their life, how we play into that. I think that is the whole purpose of what Shanta Madam had envisioned and made this entire thing possible. So, effects of violence against women on pregnancy and newborn, as Vindhya Madam said, it is kind of emotional for me also, because with this I started noticing that violence, how it acts on women with few cases. Then we did studies also. So just put it in the chat box to make it more interactive. Have you ever seen patients in your OPD who have been victims of violence or abuse? Generally, how do they present, or how have you diagnosed that there could be violence? Do they present with the telltale signs of stab injuries or beaten marks, or is it that clear always? What are the common clinical presentations, or can you recollect a case scene? If you want, you can just put it in the chat box. So these are the causes that we see visibly. I mean, the 6 causes we know: that bleeding, infections, eclampsia, obstructed labor, unsafe abortion. These are the names that we give to the causes, and we analyze by that. We make diagnosis with these names. But then when we think what is behind these causes, so not just in India, globally also, high levels of violence even in pregnancy. Pregnancy we think is generally a protected phase, but surprisingly pregnancy becomes a very vulnerable phase. If the woman is already experiencing violence, it increases even more in pregnancy. So here you can see this experience of a woman in Peru. He hit me in the belly and made me miscarry two babies. I went to the hospital with heavy bleeding and they cleaned me up. So if we don't try to find out, it's just a case of an abortion. So I'll just share 6 case studies with you, which happened with us, I mean our own experiences with the patient, and just try to be there and guess what could have happened. So this was a primee who was having a history of PROM, and we thought it was prolonged obstructed labor. Finally presented with rupture uterus and shock, and unfortunately landed in maternal mortality. So the diagnosis was rupture uterus because of, obvious neglect. But then the next day, someone had elicited history, and the history revealed a brutal kicking on the abdomen by the husband, and she was pushed violently, falling on a sharp edge. Actually, we never know whether rupture uterus happened due to that reason, and but there was definite physical violence in this case. And this was a patient who presented in the middle of the night with sudden bout of bleeding, went into shock, and she had placenta accreta previa because she was also two previous sections. She landed in hysterectomy, and we had to give multiple transfusions, etc. But again, then the next day when we went into the causes, husband had kicked her in the abdomen the previous night. So that had precipitated the bleeding. Then the third case I can never forget. I think this is the first case which really prompted to look into the hidden causes of violence in all the high risk and near miss cases. This was a woman who had preeclampsia and was brought in unconscious, and we suspected CVA, that is cerebrovascular accident, and within minutes we lost her. So the diagnosis was eclampsia with CVA, and the dead body was handed over to the attenders, and then there was a lot of hue and cry, and the parents had filed a case in the police station, and we had to send to postmortem. So actually, the postmortem revealed fracture of the skull and cerebral hemorrhage. There was very clear evidence of violence by husband, who used to hit her head onto the wall, and it was changed to homicide actually, not a simple maternal death. So a simple maternal death need not be a simple maternal death. It could be a hidden violence masquerading as maternal disorder. In this fourth case, she was abandoned in front of a hotel where she collapsed. The hotel people, they called 108 ambulance, and she was sent in active labor with previous cesarean. And when she was opened, it was a scar rupture, and we thought, okay, there were no attenders. But then the next day, somebody noticed this fractures with rods implanted in the arm as well as the thigh. So when the history was taken, actually she was pushed from second floor about 3 years back, and the case was booked, and they went to family court, and they had come back agreeing that they'll stay together, and husband has agreed that he'll not again continue the same behavior. But again in this pregnancy, she was abandoned in labor. So this was fifth case. Always she would have an IUFT. So every time the husband would indulge in kicking on the abdomen brutally, followed suddenly by the loss of. This was the history for 2 times. And third pregnancy, parents brought her home. So she was transfused blood, and she was given a live baby. Again, a very clear-cut history of physical violence by the husband during pregnancy, full-term pregnancy. So this case, again, I remember very well. She was brought in by daughters, 2 daughters, young daughters, in shock, and history of 3 induced abortions, and she had to be given blood transfusions, and abortion process had to be completed. And in the history, generally we try to blame the woman, or the attenders. Why so many abortions? Why have you come so late? Why did you neglect? Why didn't you have a family planning or a method, or all these things? Then the history again is same thing, not just physical, also emotional violence with forced abortions. All the 3 were induced abortions by over the counter medications by husband, and he would give the medication and leave her just like that as she was bleeding. And she had to receive 4 transfusions, and she was an educated girl, but he never allowed her to work. And father also supported the son-in-law because he had another daughter to marry. You all know these things. It's not that we don't know. We all are aware of such causes. And this was a case of very clear-cut, uh, physical violence. Husband was inebriated. He was under the influence of alcohol, used to beat her up regularly, and finally she landed up with this lacerations on the face. Not only that, he had stabbed in her abdomen. She was around 28 weeks pregnant. There was a rent in uterus, IUFT, and laparotomy had to be done, and hysterotomy, and then rent repair. So with these cases, we realize that obstetrician and gynecologist is a specialist stakeholder. We are not just like any other health personnel. We have a unique position to assess and provide support for women who experience violence because of the nature of the patient physician relationship that we have. And we do have many opportunities. A woman or a girl may not go anywhere, but she definitely comes to us, as Shanta madam keeps telling in her addresses and approaches, that she reaches us either in adolescence, pregnancy, family planning, annual examinations, and other women's health visits. So these are all the opportunities. And how to elicit history. Again, there is this a little bit controversy. I can't say controversy, but dilemma, whether to screen, how to screen, and all. But simply we can ask a simple question as, is everything all right at home? Are you getting on with your partner? These are the indirect questions. And there are many screening tools, mostly employed in the West. These are all the lists of those screening tools, like abuse assessment screen, humiliation, afraid, rape, kick, hark, that is HITS, ongoing abuse screen, ongoing violence assessment tool, slapped, thrown, and threatened screen, and women abuse screen tool. So many were there. And there are many studies. If you go back into literature, you see that they were screened by these methods. But then WHO in 2018 has recommended that it has told a word of caution, so that universal screening or routine inquiry about IPV is not recommended. Like asking all women at all the healthcare counter, do you face violence, is not going to help, because I'll come to that in the next slide. It wants all the health professionals to be trained as in the first line response to family violence. That is what we are probably attempting with this module, to empower all of us to be the first line responders. And the steps, as Dr. Raki has very clearly told, the lives model: listen, believe, inquire, validate, enhance safety and support. But WHO also says antenatal care giving is a setting where routine inquiry could be implemented if the condition is, if providers are well trained on a first line response and minimum requirements are met. We need to understand how we are going to talk to them, how we are going to listen to them. Raki has very, very beautifully told the solar model and everything. And the later on presentations also will address how to go look out for the support systems, how to link up with the support systems, and Dr. Ramne will tell what are the mental health issues, etc. So the concern was to ensure safety. WHO felt that the evidence, and UNICEF also, the evidence on benefits and potential harms of clinical inquiry and subsequent interventions is lacking or uncertain. So what are the benefits if we just screen without knowing how to go about it? So the minimum condition is to ask women, is to ask when it is safe to do so, that is the partner is not present, and that identification IPV should be followed by an appropriate response. Just screening is not going to help in any way. And detailed guidance and how to respond are all there in the guidelines of international organizations. With this, I end my this thing on view on how it affects pregnancy and the newborn, the violence. Thank you. I would stop. Yeah, this is one important quote I feel. Many women in many parts of the world speak the same language, the language of silence. This was said by Anasuya Sen-Gupta. Maybe we can be the voice of these silent survivors and victims if we empower ourselves. Thank you.
So thank you, Kiran. I think everyone has become silent. Either they're sleeping or they're very emotional and became silent. Yes. So these are the things, and we want to make ourselves more sensitive, and then, as I said, refresh, and we just go back into our cases, what Kiran has said, and then we also, I think,
Listening,
will also
thinking,
remember
stand
some
by
of
the
our,
cases, emotional.
yeah,
Dr. Manpreet has raised her hand, madam.
yes.
Ma'am, would you
Any
like
question?
want to say something, Dr. Manpreet?
No, you said it is not sleeping. Listening is this is, very
Yeah.
pathetic state of affairs.
Someone, Dr. Chandra says it's a stunning reality. Yes, it's a reality which we face many times in our OPDs. Anyone has anything to say?
We can go ahead, ma'am.
Yeah. Okay, then the next module, shall we start?
Yeah.
Ajay, are you there?
Yeah, very much, very much.
Yeah, the next module will be mental health issues and women who suffered violence. Dr. Ramani Devi, I welcome you to present this.
Thank you, Vidya. Let me share my screen. It's coming as host as in disabled participant screen sharing. Can you help me? Host?
I'm ready for host, madam. Can you try once?
Can I now start?
Yes.
Yes, ma'am.
Yes. Thank you. So far, we have been listening to the various speakers who were just mentioning what is the background, how we should go about, and what are the effects upon pregnancy and the newborn. First of all, let me thank Foxy President Dr. Shanta, Dr. Ajay sir, and Dr. Kiranmayi and Vindhya for having made this beautiful program of violence against women. So till I became a part of it, even I was not aware of so many things. And when we had the UNICEF training, actually it was an eye-opener. I never knew that is 1/3 of the population, women are undergoing this problem. So when the extent of the diseases or the violence is so much, then naturally there will be an aftermath. That is the mental disease mental problems the woman is going to face. Let me start with a case report whom I met in my OPD. She was a 26-year-old woman who was brought to the hospital with complaints of sudden abdominal pain. She was my regular book patient with 28 weeks of pregnancy, married for almost 1 year, and this was her first pregnancy. She was not a diabetic or a hypertensive. Usually, she used to be a very cheerful girl, very happy one. But this time when I met her, she was very much depressed. Actually, my office staff were telling, Madam, something is wrong with this girl. She feels very much depressed. I think you should go into the history of the patient. On clinical examination, her vitals were stable. Uterus was 28 weeks, corresponding to the period of gestation. FH was normal, but still uterus was slightly irritable, and vaginal examination was unremarkable. She was keeping very silent. Generally, she is not a girl who keeps so much of silence, but when we provoked her, she came out with that history of being beaten by her husband. So now the next thing is, what are the other details we need to gather from the patient? Whether we need to inform the police because it's a form of domestic violence, then how we are going to handle the patient, both her physical condition as well as how we are going to counsel her regarding the psychological part of it. What are the problems the patient can come across? I think these problems have been dealt by Dr. Kiranmayi, and whether the girl needs a family counseling. I feel strongly the family should be counseled at this junction. And suppose if she is not getting treated or getting settled with all this family counseling, her counseling with her partner, and whether she needs to be put on some drugs so that her mind gets quietened. And also we need to know what is the aftermath of intimate partner violence. So here you can put your comments in the chat box. Apart from this, what are the things you need to gather from that particular patient?
और
Yeah, from the chat box. Anybody? Extensive history taking as she is a regular patient. Very important and eye-opening sessions. How will you counseling help the violent man? He will always be violent. So these are all some of the questions. But I think if the couple are counseled, and especially if the husband is counseled by people who are good at counseling, like psychologists or psychiatrists, I think there should be some change, unless the basic nature of that particular person is going to be very violent. Okay, the next, the need of the triad of consultants. As my previous speakers, the first thing the consultant who she meets, the girl meets, is our own OBGYNs. And I'm very sure either she will open up, or sometimes if you just put a small provoking question, she will come out with like a flow of stream. She will come out with all the problems she is facing at home. So this is a very, very common scenario what we see in our OPD. Then again, of course, we need the help of a psychologist as well as a psychiatrist who can hold our hands and help these poor girls to come out of this domestic violence. Then why mental support is needed? Do you think it is very much essential? Yes, of course. Not only that particular current situation, but it leaves behind a long trail of tragedies. She may be suffering from what is called as post-traumatic stress disorder, which she perceives throughout the life, and then she may have different thoughts, and she may become hypervigilant. She may suffer from mood disorders like depression. Suicidal attempts are very common, that too, especially when these women are being subjected to domestic violence quite often when the periodicity is quite high, or they may deviate themselves to substance abuse or alcohol intake, and sometimes sexual disorders can happen secondary to this intimate partner violence or domestic violence. And again, phobias. The moment she sees her husband, she becomes very much upset, and she develops a phobia of seeing her. This sort of problems I have seen in some of my patients. And apart from this, there can be some functional GI symptoms like loss of like appetite, or as my previous speaker has enlightened, she may develop some eating disorders. She can have bowel disturbances, diarrhea, and then constipation, and so many functional GI symptoms can happen. And dissociation of symptoms, variable symptoms can happen in these women. And generally, they are very much disturbed. They have a sort of social withdrawal. They don't communicate with their family members alone, or even with their family members, or even with their friends. So the first line support mainly is only by the friendly OBGYN whom she meets. So the intervention, what as gynecologist and obstetrician, what we can do, how we can help this poor woman. First thing is, we have to go in for a risk assessment. That is, we need to talk to them how frequently she meets this sort of domestic violence, or what is the severity. Sometimes it may be a verbal one which may not have a physical harm, but on the other hand, she may be mentally affected very much, or it may be a physical violence which will amount even to the sometimes like grave injuries, like even fractures can happen, and how chronic this sort of problems she has been facing it. Again, safety from further assault from the partner, we have to assure these girls how she should protect herself from the further attack from the partner, psychological screening, suicidal tendencies if she has had, then we need to definitely support them psychologically so that she comes out of the suicidal tendency, as well as danger assessment. Then again, we need to assess the domestic homicide risk. That is also again very important, especially like in case of problems that is faced in the house, in the mother-in-law's house, not only by the husband, but also she faces from that of the parents-in-law. We have to assess the risk, and probably we have to guide her such that she is being taken away from this homicidal risk also. So the danger signs are frequency, what I have mentioned, more how frequent it is, and presence of severity of the injuries, alcohol misuse, threatening to kill. It is not only by the husband, but also by the household member, sexual violence, suicidal ideation in women, access to weapons, and morbid jealousy in the partner. So now we having got this details from the patient, we should know whether we need to hospitalize the woman or take her to a very safe place where she can tide over the acute crisis and plan for the next thing, how she is going to face it. So first one is, when there is a severe medical injury, of course, definitely she needs support from the medical side. And when she has suicidality or homicidality, again, we need to take her to a proper safe place where she will be devoid of this problem. Dissociative or psychotic symptom should be assessed by the psychologist, and we should help them. Mood instability and affective dysregulation. This is again, mood instability is very, very common after a domestic violence. And this is the basic for this mood instability is the basic for further suicidal tendencies or further provoking her self-injury, self-inflicted wounds, all those things. Self-destructive behaviors, if she has, or serious threat to the patient life from the perpetrators, then we need to get these women hospitalized. Individualized multidisciplinary treatment plan. Primary treatment modality is, first is safety assessment. From identify whether she has got a suicidal or a danger assessment. Milieu is the social environmental therapy what we can offer to them. Help them to have a mood stabilization. Go over a detailed medical evaluation. Give a psychosocial support. And in case of rape, we need to have a rape kit, photo documentation, reporting legal concerns. These are all some of the multidisciplinary treatment plans. Trauma recovery clinic. The objective of the trauma recovery clinic, that is following this domestic violence, a post-traumatic stress disorders or any form of physical or mental sufferings the woman undergoes, we need to have some form of trauma recovery clinic so that it will enable the survivors to come to terms with trauma, reclaim lives by reducing emotional symptoms of trauma, enhancing self-esteem and resilience, improving the social support, prevent re-traumatization, conduct awareness and capacity building programs for psychologists and counselors. These are all very important because unless we are, as counselors or psychologists, we are exposed to this particular problem and have an awareness among ourselves, we cannot treat this or handle this domestic violence patient. Then again, we can have such clinics in any multidisciplinary center, which is going to be the need of the hour. One such clinic has been started in 2014 at NIMHANS. Then psychosocial impact. So the woman feels that she is helpless, and progressive erosion of that will lead to progressive erosion of the confidence and self-esteem that is caused by abuse. Again, sometimes the patient can have a feeling of guilt, shame and isolation. That is most important. And this is what I felt. Paradoxically, this traumatic bonding can strengthen the emotional ties to the perpetrators. Then again, physical separation due to increased risk of homicide. So the girl will be so scared that she wants to get rid of the physical separation is practically needed so that she can escape, save her life from the risk of homicide. Decreases coping ability with the victims. So these are all some of the psychosocial impacts. And what's the role of psychologists? They play a main role in treatment, assault psychotherapy, cognitive behavioral therapy, or exposure therapy. A variant of cognitive behavioral therapy helps the victim to emotionally process assault by decreasing the severity. This is very, very important because sometimes this particular lady may be having some sort of emotional stress, and her thoughts about that past memories will be reverberating. So she needs some sort of cognitive behavioral therapy to come out of that situation, so that she will not have any suicidal tendencies or some form of depression, etc. So brief trauma-focused cognitive behavioral therapy are essential. Accelerate the recovery in victim in acute cases. So there is a role played by the psychologists and the psychiatrists to help the victim to overcome this or recover fast in cases of acute situations. And interpersonal regulation. Psychoeducation about the impact of trauma on emotions and relationship. We have to educate them. Emotion regulation skills, effective expression of negative emotions. We should somehow pull these women out of the negative emotions, out of the reverberating, especially depressing scenes that she has come across. Interpersonal skills related to appropriate assertiveness, development of flexibility in regard to interpersonal expectations, actions, and reactions. Treatment also includes recognition of achievements during treatment and exercise in self-compression. So interpersonal psychotherapy is shown to be effective in non-exposure based treatment for post-traumatic stress disorder. Most of these post-traumatic stress symptoms reflect on interpersonal difficulties such as emotional withdrawal from the relationships and individuals, and interpersonal deficits, that is persistent loneliness, sometimes resulting in the interpersonal hypervigilance. For example, the girl who undergoes this domestic violence, she wants to keep away her relationship with the husband and the husband's family members or the perpetrators. Then she, something like snail that draws inside that shell, she may be persistently remaining loneliness, and she may be constantly having reverberations about the past happenings that will result in interpersonal hypervigilance. So this interpersonal psychotherapy includes cognitive processing therapy, that is CPT, eye movement desensitization reprocessing, that is EMDR, and HOPE, helping to overcome post-traumatic stress disorder through empowerment. This is very, very important. Again, we need to educate these women how they should come out of this post-traumatic stress disorder, either by that goes only by through constant counseling. Relapse prevention and relationship safety. These are all the 4 important things, newer psychotherapies, which will help the woman to come out of this. So the psychological therapy in women experiencing intimate partner violence related depressive disorder or alcohol disorder should receive mental health care as per WHO Mental Health Gap Action Program Intervention Guide that was released in 2010, delivered by healthcare personnel with good understanding of violence against women. CBT and EMDR interventions delivered by healthcare professionals with good understanding of are recommended for women who are no longer experiencing violence or suffering from PTSD, that is post-traumatic stress disorders and depression. So WHO recommends for depression and other emotionally or medically unexplained complaint some sort of drugs, like there can be a role for antidepressants and benzodiazepines, or you can give fluoxetine, and the duration of the treatment, it should be continued for a period of 9 to 12 months. Early withdrawal can cause agitation. Brief structured psychological interventions like interpersonal therapy, cognitive behavioral therapy, including behavioral activation and problem solving treatment, and relaxation training, physical activity, and during the relaxation training in women who are in the below the poverty line, or we should be providing them with some sort of training projects which will help them to support themselves, earn their livelihood, and psychological support after recent traumatic event. We have to go for debriefing, psychological first aid, and acute distress are essential. Men, group treatment therapy. We have to encourage the men to take personal responsibility for violent behavior. So men therapy is also
ब्रेक ही ब्रेक है वैसे तो बहुत देर से
there is a background talk.
Please mute all.
Mute everybody. Mute everybody. Okay.
दो बादाम लेने तो
Yeah. So encouraging men to take personal responsibilities for violent behavior. I personally feel this is very, very important, because the men who indulge in domestic violence for the first or few times, maybe if we can talk to them, if we can counsel them, and most of these men are able to come over that, so that this becomes a very important part of the treatment therapy for mental illness. Challenge attitudes and belief around the use of violence in a relationship. See, we can always talk to them that how their relationships are going to get affected because of domestic violence, and how there is a brief in the family relationship, plus the children are affected. So if we can talk to them, counsel them in a detailed way, maybe they can, it can be of some use. And again, developing skills for reacting non-violently to others, that we should tell these men. The partners may behave in a different way. They should be taught about the skills to react non-violently in case if they want to show their some form of difference of opinion between the couple. Again, increase the awareness of dynamics involved in the use of violence. To conclude, mental health is an issue in violence against women, affected by women, and thus needs to be addressed along with physical health. So both put together, mental health as well as physical health put together, will help the woman who is stressed, pressurized because of domestic violence to come out of it. Thanks for the opportunity given. Now it's the pre-test and post-test and feedbacks are welcome.
Thank you, ma'am. Ramani ma'am, for that very elaborate and very useful presentation. Ajay sir?
Yes.
Yeah.
Thank you, Ramani, for telling us and reminding us of all the psychological problems and how to elicit the history and how to deal with them and how to rehabilitate them. And the thing about one more comment, small comment about counseling the men is a difficult task, because, you know, I don't know, we can try, but it may be difficult. First thing is they don't come for counseling.
Yes.
And once they go back to their normal self, and in Telugu, I don't know, some of the Telugu girls can understand kukka toka vakkara, because the dog's tail is all curled, you know, how much ever we try to make it straight, it will curl again. So thank you very much.
But maybe I think we can make an attempt. See, sometimes when it is going to be the first episode, they do it like momentarily.
Yeah.
So maybe we can't attempt
we
it.
have
but
to make an attempt.
We
There's
have
no
to
other
make an
choice.
attempt. That's
Yes.
what I feel.
Unless men become partners, we'll not be able to erase
Yes.
this violence, ma'am. Because, you know,
True, true.
So that's the basic thing of us doing the school programs also. Dheera school programs,
catch them
that
young.
we
Catch
can
them young.
avoid all these programs later on,
Yeah.
after a decade or so.
Yeah,
Okay,
we
fine.
have two, Dr. Sunita and Dr. Vidhu raised their hands, sir.
Yeah, thank you. So I'm Dr. Sunita Singhal. I'm from Delhi, AOGD member. So I just want to share a couple of my experiences. You know, I worked in Safdarjung Hospital all my life, and I've seen even worse cases than what you all have been showing. So I just want to talk about the challenge of, you know, addressing men, you know, how to address them. It is a big challenge. Sometimes it is counterproductive, but sometimes what has worked is that if you can get hold of men's influencer, the abuser's influencers, and those could be his friends, his office colleagues, or some other people. So those people, sometimes if you can catch them, it is not easy, but it has worked sometimes. So sometimes they can bring them around initially, and then later on, you know, of course, our counselors team and all can take it further. So I just wanted to, you know, mention this, which I've tried and worked sometimes.
We try next time, and that's a very good suggestion actually. Thank you, Dr. Sunita. Someone else also had a question. Vidhu?
Vidhu had a question.
Yeah, I just wanted to share my own experience. As I've been practicing for so many years, when you see even young children who are coming with some kind of a problem, when you take a detailed history, you come to know that there has been some kind of violence with their mothers, you know, and that is leading to so much psychological impact on them right now at adolescence. And they come with so many weird problems where actually they have no problems. So yes, violence does play an impact on a child at his young age, especially if he is seen at his home with his mother or someone.
Intergenerational, intragenerational.
Yeah.
Okay. Shall we go to the next topic? Dr. Kiran Mai now will tell us about challenging situations in violence against women and self-care of for service providers. So Kiran?
Yes, ma'am. Thank you, ma'am. So again, as we have seen since the beginning of this module, it does get to us emotionally, psychologically, when we are dealing with these patients and situations. Okay. So the first part is challenging situations in violence against women and how to take care of ourselves as service providers. So what could be these challenging situations? A survivor may be feeling extremely hopeless or having suicidal thoughts or about to harm herself or others in the process of when she's confiding to you or when you are trying to find out. So this is again a small situation. Just put it in the chat box. You are a gynecologist, and in the course of your talking with your patient, she tells that she's being threatened by her mother-in-law, who is constantly pressurizing that she must divorce her husband, or her husband, because she's unable to have children because she's suffering from infertility. She feels hopeless and wants to give up. Now, what would you do? You would do something or you would do nothing? What do you think? Just put your answer in the chat box. Okay, I'll go to the options. So there are some ideas here. So as Ramani madam has told us, we should be able to recognize the clear-cut signs of depression and the risk of suicide And it is important to ask, are you having thoughts of suicide? We'll discuss this again in the next slide. And if the answer is yes, take it seriously. Do not leave the survivor alone if there is an immediate danger. Again, Raki had told that we have to either take help of our seniors or other team members. Never deal it with your own, alone, because this is for your safety and well-being. And involve a gender-based violence expert if you have, or an agency. I seem to understand many of it's a good sign that many places, districts, and centers in India have these government one-stop crisis centers. We also do have here in Barosa. So we can always link up to these agencies or crisis centers or multidisciplinary teams or trauma recovery centers if possible. Then again, this question was put to us in the UNICEF training, and which I learned only in that training. Obgyns should not ask survivors about suicidal thoughts or attempts. It could encourage suicide attempts. Is it true or false? We should openly ask about any suicidal ideations or not. Yes. No. Yes, yes. No. No. Most are saying no. Okay, so this was what we answered. I answered at least that we should not. But then it is, we should ask. Asking about suicide attempts or thoughts, it does not increase the suicide attempts. On the contrary, talking about suicide often reduces the woman's anxiety about suicidal thoughts and helps her, she feels heard and helps her feel understood. So it is nothing, there is nothing wrong. If you have a doubt, you can go ahead and ask whether that suicidal thought or thinking is there. And if a survivor tells you that abuser has threatened to harm them, now the one situation is where she is contemplating suicide or so depressed that she is trying to harm herself. The other is when they say that abuser has threatened to harm them and that she is in a serious danger. Now what you should do? Put your answer again in chat box. Again, a few ideas. Instead of saying a clear cut solution, because nobody has, we should ask concrete questions about the safety risks, and also very important that only when there is privacy. We cannot discuss this when there is someone else, especially her partner. So ask the survivor if she has thought of any safety plan in case she needs to flee. And then you can discuss the strategies, what are all the possibilities or support centers, her support systems, her own family. And then again provide a referral to a GBV expert agency or one-stop crisis centers for additional help if possible. So one of the most, now while you're dealing with this both situations, either suicidal or that she will be harmed by the abuser or partner, while you're talking, one of the most helpful techniques is to get her out of this overly emotional state, either suicide or homicide risk or physical injury risk. The person or woman would be very emotional. So to bring her out of this is the first thing. So here we ask closed end questions, not open ended. Closed end questions are questions which have a simple answer, so which require them to think, not feel. Questions that make them feel make them more emotional, whereas questions which require them to think will get out from their emotional state to a cognitive thinking state. And the question should be such that which require short answers. Generally we use this when we are trying to pacify a woman on operating table when she's anxious. We do ask them what their children's names are, how many children she has, whether they are going to school. Most of the times it gets her out of that anxious state and she starts conversing with us. So again, do not return to open-ended questions where survivor, unless survivor feels comfortable and that she feels that she can discuss or that she got back some of the emotional control. So what are the some of the closed-end questions that you might go ask in a situation like this? You just can put in the chat box. Some examples are, how many kids do you have? Very simple answer. What are their names? What are their ages? Are they in school right now? What ages are they? These are simple thinking questions, not emotional questions, with simple answers. Now, when you are dealing with a survivor who is mentally ill, this is another challenge. So Here also, you have to state clearly who you are and your role. Be empathetic. Empathy and sympathy are again and again will come in our module, because it is important to develop an empathetic attitude, not just for the patient's sake, but also for our own self-care. It should be non-threatening, and you should be sound sincere in your intention to help. Give honest answers. If you do not know, say so. And again, don't promise help when it is not there. And do not belittle concerns which the survivor raises. Then again, supportive in comments, gestures, all these things. Again, Raki had very clearly told. And again, we need to have, most of us do not have this, I feel. You can share your thoughts to link up with emergency mental health backup. We do have now some linkage to emergency, I mean, the one-stop crisis centers for violence. But do we have emergency mental health backup where we can activate it and immediately enlist their support? That also is important when we are dealing with a severely mentally ill patient because of violence. Then additional challenging issues. Again, this was one question which was very interesting. Can we be part of the mediation process, like between the man and the husband and wife or partners? Is it our role? So again, mediation is not recommended as a response to gender-based violence, because we are part of the survivor-centered referral mechanism. The mediation process maintains and contributes to the abuser's ongoing power and control over a survivor. And the process of mediation presumes that both parties can speak freely, confidently, and safely. Actually, this is not the case. We are on the side of the survivor. And mediation rarely results in an end to the violence, and actually leads to an increase, because the abuser feels empowered, because you are giving him a platform to speak and support himself. And it is unlikely that this survivor's rights are respected. So mediation is not done. It is a no in a situation of conflict. And always remember, enlist multiple people, have a team. Don't work alone with the survivor, and don't work with both the perpetrator and survivor. A single service provider should not work with perpetrator and survivor together, neither separately nor in the same interview. And always keep the office door open, or if feeling unsafe, or an alarm, and establishing a code word with co-workers to identify unsafe situations. And establish a relationship with local police or security, again, crisis centers or police stations. Using buddy system at work, you need to unburden yourself. You cannot, it gets to you if you are continuously working in such situations, or GBV centers, or the GBV helplines. Even as healthcare providers, it does get to your health. So having a buddy system, mostly army people have this buddy at work and to and from work, and if doing home visits. And again, supervision, a group of people can address security more effectively than a single individual. Then coming to the self-care for the provider, because it is very critical. Do you know what is vicarious trauma? Just put your comments. What is vicarious trauma? Have you heard of this word? Few seconds more. We suffer their suffering. That is what Dr. Padmaja says. Okay. No, mostly no. Though I thought I understood, but I completely did not understand the meaning unless it was explained with examples to us. What Padmaja says is more or less true. We kind of suffer their suffering. That is vicarious trauma. So, sorry. So as a service provider, you should be aware of it for your own self-care. So what is it, vicarious trauma? How do we define? A change in a service provider's inner experience as a result of emotional engagement with survivors of trauma and hearing their stories. And changes that occur in the service provider's physical, emotional, or behavioral states as a result of constant exposure to traumatic stories or events. This is vicarious trauma. So again, you feel that you have to change the survivor situation. When you are not able to, so you feel powerless, helpless. And if you don't see immediate change, and you're identifying with the survivors all the time, you're thinking about it all the time, and you're thinking that you have the power to change a survivor situation, which is not so. So again, how do we manage? It is ABC: being aware that such a vicarious trauma exists, and being attuned to our limits, emotions, and resources, and practicing self-acceptance, And maintaining balance between activities, especially work, play, and rest, like unfocusing and focusing. When at work, you are working, and when you are away from work, you have to disengage from that work atmosphere. And positive emotional and supportive connections with friends, your family, and the society. This can help prevent isolation and increase validation and hope. So, again, creating boundaries in the workplace, not taking up extra load of work even if it is beyond your capacity, or establishing, not seeking support, establishing support within the work environment, seeking assistance from outside agencies, even mental health support if needed, creating your own self-care plans and following them through. Again, empathy and sympathy, I'll not repeat it. So empathy is important. We should put ourselves in the survivor shoes. It involves compassion and objectivity and leaves room for empowerment of the survivor. So we have to have empathy, not sympathy.
मेरे कहने का मतलब ये है कि बोलने से मत डरिए। जैसे सपोज हम लोग थोड़ा एक मिनट आ रही हूँ, सपोज गंगा जी सब लोग अपने घर में एक
Dr. Sabita, can you mute yourself? So how do you take care of yourself? Just in the chat box, relaxation and self-care you use. So generally I do gardening, and then I read books. You may like music, or you unwind it, have some healthy habits. Meditation, many are saying meditation, yes, very important. Mindfulness, singing. So important to take care of ourselves. With this, I end my presentation. Thank you. Yeah, shall we go for the any important comments or something to be discussed in the comment chat box, sir?
This was
Dr. Sabita can be muted, please. Yeah, she's unmuting herself repeatedly.
Yeah, this has been such a wonderful session, Kiran bhai.
Thank you,
Many
sir.
times, we always put the patient on first, patient first, patient first, then tend to keep forgetting ourselves. And it's so very critical that we realize this bit about this. It is somewhere there in the back of our mind, but many times we forget to take some action for it. And I can see a lot of people have put some actions over there, meditation, pick up new hobbies. So Janani, I would like to know what new hobby you have picked up. I can see Rani, music. Shalaka, next time you're going to sing for us. Yeah. That will be awesome. Yeah, let's have a duet together. Yeah.
Friends,
and listening to music, humming, yes, that's a very good thing. Yoga, yes, does help. Or just talk to friends. I know, Anju, that's the best time pass one can do, and you can get the juicy gossip also, right? Yeah. But yeah, that's interesting. Yeah. Thank you, Kiran Mai, once again for doing this. Raki, can I request you to please take over from here? Is it possible for you? Because Vindhya has just left the to talk about the next speaker and give your summary of it.
Yeah.
Sorry to put you on the spot, Raki, like this. I sent you a message, but I think you didn't see it.
No, I read.
I think next is Dr. Anita, right?
Dr. Anita Sabharwal is going to take it. She's going to talk on support system rehabilitation and resources for survivors. Let's see what we can offer for them.
1 minute, just give me a minute. Oh, I think the wrong slide is coming. 1 minute. I don't know why this slide only is coming.
हो रहा है तो ठीक है.
Huh?
We cannot
और
see
क्या?
the slide, Dr. Anita.
सबके अपने अपने कारण हो सकते हैं.
Share, because this is the, I think the module 3.
Yeah.
But
No,
it is not showing on the screen.
it's not showing on the screen, ma'am.
Again,
Okay, okay. I'll do it again.
It's the module 2, say, third talk.
Yeah, yeah.
It's
No,
not
I
narrow.
had checked that time, no? So that time it was coming.
Yeah.
But at the moment it's giving me problem. I don't know why. So it's not coming. So no. So 1 minute. Just give me a moment. Then I'll just. Yeah. So
Anita, you want backend to help you?
yeah, I'm trying. Somewhere I'm lost, and my Zoom is also not coming now.
No problem. Sriman, can you share slide presentation number 6?
Yes, sir.
Thank you.
But I have to go back to my Zoom also. No, I'm not. Yes, now I've come back. Okay, I've come back here. 1 minute. Yes, so if you could share my slides.
Yes, Sriman. Sriman, do you have to download them? Is it?
Yes, sir.
Okay, can you download them in the meantime?
Shall I do it?
Oh yes, Kiran, if you can do it, because I also have to download it. I was doing that.
Just a second. I have it.
This is a slide, sir.
Okay.
Yeah. Okay, got it.
Got it? Okay.
Yes. Yeah. So shall I start?
Yes, ma'am.
Can you hear me? Yeah. Thank you so much for bearing up with me. And before I go on, I must thank Ajay sir and Dr. Kiran, and of course the entire team, and of course our president Foxy, Dr. Shanta, for giving this opportunity to all of us, the women, ourselves women who are also part of this violence. Maybe, I'm 62, and I think I have also gone through somewhere or other, somewhere I also came across this violence. And because everybody just now, we were just listening to everybody, so we all know that women are the essential part of the society. And still we know that they have always been the vulnerable section of the society. But at the same time, women have the right, they have the fundamental right to a life which is free of violence. So next slide, can we have? Next slide. Sir, can I have my next slide? Yeah. So we have, there are various protective laws and acts. There are different helplines. And we were just mentioning during previous lecture, there are different crisis centers. We call them one-stop crisis centers. And then how they can be linked up and help in rehabilitation of the survivors. So next slide. So we'll go through all of them one by one. Next slide, please. So, this is a very, very important act, the Protection of Women from Domestic Violence Act. which came up in 2005 and started acting in 2006. And this act may be called the Protection of Women from Domestic Violence Act, and it extends to the whole of India, but it doesn't extend to state of Jammu and Kashmir, and it shall come into force on such days as by the central government notification in the official gazette. So next slide, please. Next, as Dr. Ajay said, I'll keep saying next. So why Domestic Violence Act came up? We already had 490A into the Indian Penal Code, which was introduced in year 1983. But in that, there was no emergency relief available to the victim. And the remedies which were available, they were linked to matrimonial proceedings. And the court proceedings were always protracted. That is, they were so long, during which period the victim was invariably at the mercy of the abuser. So many years used to pass and the victim had to be at the mercy of the abuser. And the relationship which were outside the marriage, they were not recognized. Next, please. Next slide, sir. Yeah. So why this law came up? Because this is a civil law. And in this 498, husband, he does not get, the woman doesn't get any financial relief, though husband is liable for punishment. But in this Domestic Violence Act, wife or the female partner, she gets relief, but there is no punishment or arrest of the husband unless he violates the court order. And another difference is 498A, it can be booked against husband or his relatives, but in the Domestic Violence Act, it can be booked only against the male members of the family, not the female members of the family. Next, please. Next slide. Now, who can be a complainant? Who can complain? A wife, she can complain, or a woman based on the consanguinity, marriage, adoption, and cohabitation against a male abuser in a shared household. Or a woman who is in relationship similar to a marriage with a man. Or even technically a transgender male to female could bring an action against a transgender female to male. And now in a woman who is in a live-in relationship with an unmarried man, mind it, with an unmarried man, but not with a man who's married if she knew or ought to have known that he was married. And then anyone can file a petition with the survivor's consent for the survivor. Next slide. So now we know who all can be a complainant or who can complain. So now this we just learned that who all can complain. Now to whom can we complain? Now we can complain to various people. The woman can complain to a protection officer, to the service providing center, and then to the medical officer in charge. She can also complain at a police station, or she can go to a magistrate directly. So these are the places where she can complain. Next slide, please. So the jurisdiction under this Protection of Women Against Domestic Violence Act is where wife permanently or temporarily resides, or she's carrying out her business or is employed. Or she can also, the jurisdiction is where her husband is permanently or temporarily residing or is carrying out his business or is employed there. Or she can complain at a place where cause of action has arisen. So the wife has the liberty to choose any of these three options. So wherever she finds it convenient, she can go and complain. So this is the jurisdiction which comes under that. Can I have my next slide? Next slide. So now there are different types of orders which the protection officer or wherever the complaint has been done. The orders are protection orders or stop violence, emergency relief can be given, or the residence in shared household, irrespective of whether she has any right of ownership or has any lease, she will be given. She can require a separate housing and abuser has to provide. Even she can take the custody order of the children. The compensation order can be passed, and violation of above order, which is an offense, and then the magistrate can charge this offense if this order is violated. So the husband has to follow the orders, and otherwise he will be charged. Now, the non-compliance of a protection order by magistrate, it can lead to issuance of non-bailable warrant. So this is very, very important. So this law really gives a lot of protection to our women. Next slide. Now this time prescribed also by the Protection of Women Against Domestic Violence Act, because as we said earlier, it used to be very, very long under the 498. But in this act, this requires that all proceedings which are brought under this act, they have to be disposed of within 60 days or 2 months of the first hearing. And that first hearing which must occur within 3 days following the application. So this is a very, very helpful and good for the woman, because it takes place very quickly and it has to be completed within 2 months. Next slide, please. So now under this act, what all the services are offered to the woman? She can file a detailed investigation. They have to help her to file a detailed investigation report and direct the complainant to a shelter, because if she has no place to go to or live that time, so she'll be directed to a shelter, and also she will be facilitated to have free legal services. So the women have to go and ask for them, and she would be given. And she is also provided counseling services as required as per this act. Next, please. So the domestic legal remedies in India as such, this is the latest which we were talking about, the Protection of Women from Domestic Violence Act, that is PWDVA 2005. Otherwise, the Constitution of India, the Article 14 on equality, the National Commission for Women set up as a statutory board in January 92 under the National Commission for Women Act 90. The Dowry Prohibition Act, we all know, and this 498A Indian Penal Code, which we were just talking about, this is the most widely used provision against domestic violence. Protection officer, is as the question is coming in the chat box. Protection officer, the state government has, these are the official people, protection officers by the state government, who are there to help the women. So next slide, please. Next slide, yeah. So now, as we were discussing previously, that we have the concept of the one-stop crisis centers. So these one-stop crisis centers, they cater to the immediate, medical, legal, and psychological needs of women who are survivors of this physical and mental abuse. We can understand from our recent, just a day back before, the such horrible incident which happened, that how much a woman goes through, So that time she's so much under stress. She needs a lot of mental and psychological help, legal help. So these centers, they cater to these immediate medical, legal, psychological needs of the women who are survivors of physical or mental abuse, with an assurance that their consent and confidentiality will be respected and also protected. So there are various centers all over India, almost 234 centers we have. They are also known by the name as Sakhi centers. Like in Madhya Pradesh, we have Goravi. It is a joint initiative of the Department of Public Health and Family Welfare by the government of Madhya Pradesh, and Action Aid supported by Police Department. So Goravi staff of 10, they focus on the victim's need. They are only solely focusing on that, and they are for that only, without compartmentalizing services. And it is since June 2014. Next slide, please. And then we have Bharosa Trust. As you can see, Dr. Shanta ma'am here. This is at Hyderabad, Brodha Center and the She Team Office, we call it. All in one for violence against women, with police, with counselors, with psychologists, legal advisor, medical help, so that woman doesn't have to go from one place to another. Already she is so much under stress, tension, and even the brain doesn't work, where to go, how to go, whom to approach. So if you go to one center and you get everyone, it really helps the woman a lot. And the helpline is 100, and she will be directed to Bharosa if it's violence, because 100 is the number everybody knows, and the moment she will tell her problem, she will be directed there. A woman can walk in with the assurance that again her consent, her confidentiality, that will be respected and protected, because this is why most of the women are scared to go anywhere, because they're scared that everything will be told to others, and then others might take advantage, undue advantage, and they may further go into trouble. So next slide, please. So this is a Bharosa we were seeing. So services of one-stop crisis center, as many of us were interested in these one-stop crisis centers. These centers cater to our women who are disturbed and traumatized and are facing the violence. So they are given medical treatment, they are given social reintegration, they are given a safe custody or the shelter home they are directed to, they are rehabilitated, psychosocial counseling is done here, they are sent to social welfare services so that they can again help them for their welfare in the society. The legal support is given free of cost, and the police also has to assist, and forensic DNA test, if and as required, would be done over here. Next slide. Next slide, please. So this was all about this crisis center. So we have various, helplines, All India Women Helpline, which is Women in Distress. So we all know these numbers, 1091, and Women's Domestic Abuse Helpline is 181. National Commission for Women, you can see these two numbers over here. They are in Delhi. Then Delhi Commission for Women also we have separately. Then Outer Delhi, we have these two numbers. Then there are various local bodies, local champions, the NGOs, and the police station. So you have to find out your local city helpline numbers, and that you can share with your group or with the school or the person who requires. So next slide, please. So we'll be just sharing with you all the various numbers, because in our country we have them, these centers all over the states and all the union territories. Like in Andhra Pradesh, we have Bhumika Women Collective, Protective Cell, and then we have in Arunachal Pradesh and Bihar. So all these, next slide. Andaman Nicobar, as you can see over here, I need not read each and every line. You can just see that every state, every union territory, Chhattisgarh, Daman and Diu, and then we have Dadra and Nagar Haveli. So all these places in Delhi, all these places we have, these are the places. And we have also the numbers written over there, the different foundations, different commissions, so they can be contacted over there. So next slide. Again, we have a whole list, for various states and various cities, various union territories. In Gujarat, we have like Awag, Manav Kartavya, SSKK, and Hari Raj. In Himachal Pradesh, we have Jagori Rural Charitable Trust. I could read in the chat box, somebody was mentioning in the Patiala city also in Punjab. Then Jharkhand, they have Grameen Vikas Trust. And in Jammu and Kashmir, they have Peace Inside. Karnataka, they have Planet Mars Foundation. Kerala, they have Bodhini, and different phone numbers of Kerala police are here. So these helpline numbers, they will get you the help you need in every state and every union territory of our country, India. Next, please. Next slide. Can I have it? Yeah. So, so different, even in Mumbai, Maharashtra, you have so many places over here. Mumbai Police Women Helpline, the Railway Police, the Navi Mumbai Police Station, Maharashtra Women Helpline, Manipur we have, Meghalaya, Mizoram, all the places, Nagaland. So all these helpline numbers, they will help us in the time of need. So the women have to just, they have to just come out and contact these numbers, and she would be helped. So as we say, the one step you have to take, and then you will get all the other steps where you will be helped a lot. But you have to come out. Odisha, then again, you can see over here, the Odisha, the Puducherry, in Punjab Women Helpline, Punjab, in Amritsar, And I just, ma'am was mentioning in the chat box, Patiala also part of Punjab. So Chandigarh also, Haryana also, Rajasthan also. I don't think any place is left where we don't have these helpline numbers, which will get us the help which we need at the time of the need of the woman when she is under this domestic violence. Next, please, next slide. Can I have the next slide? Yeah, again, it's just going on. I think these are the last slide of the numbers. Tamil Nadu we have, Tamil Nadu State Commission, Telangana we have, Tripura we have. Dr. Patel was, it's a very remote place. He was there just 2-3 days back for a camp. So he was telling us very remote, but still we can see here Tripura Commission for Women. And then in Uttarakhand, Women Helpline is there, Uttar Pradesh Women Commission, and Uttar Pradesh Women Helpline. So all these helpline numbers that will get us the help we need in every state and union territory. So we just have to know the numbers, we have to know the places where all they have. And I think each city, each state, they have so many helpline numbers. And can we have another slide, please? This was again the West Bengal. There also they have the Women Commission. They have a helpline number. Then Swayam NGO and the Bengal Commission for Protection of Child Rights. Even the email they have mentioned. So one can, even the woman, if she's illiterate or the woman, she is not able to do the network kind of work. So she can take the help and she can even reach these people through these sites. And next slide, please. So ultimately, it's we women, and we all have to help all our women. And also we have very good men with us who are at the back of us, like Ajay sir. So if we all together are there, I don't think we will be far behind in helping all our women and preventing such disasters which are happening and which really happened in our own fraternity, where our women who are so highly educated, the cream of the country, very professional, the gold medalists, even they suffer. So I feel if we are all together, we all can prevent all this. And so again, the last slide, as we've been saying after each presentation, that registration and after the pre-test, which you all must have done. And now please give your post-test and feedback so that certificate could be awarded to all the participants today. Thank you so much. Thank you, sir.
Thank you, Dr. Anita. I think we are more learned by understanding where all the patient needs to report and with all the helpline numbers. And are there any queries from anybody?
Who and Dr. Jansi have raised their hands.
Dr. Jansi and Dr. Vidhu. Dr. Jansi, do you want to say anything?
Unmute yourself, please. They are both muted.
Dr. Vidhu has a, I don't know.
No. Dr. Vidhu का हाथ चला गया, पहले का question होगा. And Dr. Jansi,
I think.
Okay.
It's okay. Let's move on ahead, I think. If there's anything, kindly you can write it down in the chat box so that we can address that issue. Moving on to the fag end of it, we've got the third module running now. It is on sexual violence, how to approach a woman facing sexual violence. And if you could start doing it now.
Yeah.
Jyoti is there? We've got Dr. Jyoti or?
No, Jyoti is not there.
Okay.
So let me help out with this presentation.
Yeah, over to you, Dr. Ajay. Who else can do better than Dr. Ajay?
Not like that, I know.
मैंने मैसेज पढ़ा तो फिर मैंने निशा जी से कहा.
Okay, is my slide visible now?
Yes.
Okay,
yes, sir.
Yeah, so we've heard a lot about what is violence, what are the various types of violence. You've also heard about various strategies and also making sure you put yourself first in all of this, system. And various case studies have also been discussed in terms of what are the important signs and symptoms one should look for, and what kind of possible strategic approach one can take of involving the husband or the family. So there is no one size fits all. Like you go to a shop and buy a shirt or a kurta. You have 42 size for a whole lot of people. So here you're talking of human beings and human emotions, and therefore one needs to deal with them accordingly to the best possible manner, and keeping yourself safe, keeping yourself up to date. So sexual violence and how to approach a woman facing sexual violence is the topic. Essentially, we start off with talking about how is it defined first and foremost. That is important for us to know. Many of you must be knowing about the definition, but it's defined as any sexual act or attempt to obtain a sexual act or unwanted sexual comments or acts to traffic that are directed against a person's sexuality using coercion by anyone, that is force, regardless of their relationship to the victim in any setting, including home, at work. So those are the key things. It doesn't matter where it happens. And if it constitutes anything related to this, it is sexual violence. What is rape? Rape is the term which is commonly used for the first type of sexual violence mentioned, whether it is forced or coerced intercourse. WHO defines it as a sexual violence, which includes and is not limited to. Can we mute yourself, please? Which is defined as physically forced or otherwise coerced penetration of the vulva or anus using a penis, other body parts, or an object as well. So it's not just bodily force or violence or an intercourse, but it could be any object as well. So it is very broad in terms of its definition and encompasses everything that possibly can constitute a rape. There are critical facts about sexual violence. Chances are that you know someone who has been sexually assaulted. Victims usually know their assaulter. Victims are never at fault for a sexual assault. I mean, you cannot blame the victim that you were dressed like this, so you had an invitation. No. Rape is the least reported and convicted violent crime in the world. And we have seen that in our country also. Every 15 to 20 minutes, there is a rape happening somewhere in our country, which goes unreported. And talking of conviction, it could take several years before a conviction can actually take place. It is preventable, definitely, and help is available. Why did you seek out that help? And we have seen in the previous presentation, several numbers have been given, which can be shared with all of you when we go along, so that you can either take a printout of it and put it in your clinics for your relevant state, or you can share it with anybody whom you feel may be requiring the same.
Ajay, good evening.
Oh, you're here? Great.
Yeah, I just joined for a minute. I'm extremely sorry that I couldn't join this launch of training of trainers of the second module. Okay, because I was busy with this Jaipur incidents of Archana Sharma. We are trying to sort out and see what best can be done against this violence against doctors also. Okay.
Yeah. Welcome, Shanta.
So that's why I joined late, and I'm sure all of you are doing a great job trying to put the curriculum in place for this Dheera second pillar course.
Yes.
So that will be a great this thing. I really want to appreciate and congratulate all the Obgyns, Foxians who have joined for this training. And thank you all the members who are taking forward the Dheera online school certification program. It will make a difference if we actually catch them young. And I think now along with this, we need to look at how we need to sensitize the public against violence against doctors also. And I think we should start it young. Along with no to violence against women, I think we need to have one small session where they should not show any violence against the people who are taking care of health. I think that's also very important. You see if you can add it, Ajay. I think we should try to see if we can incorporate it in this pillar.
Sure, sure, sure.
Thank you very much.
Thank you,
So,
Shanta.
Yeah, thank you, friends. And I'm really sorry for joining very late and leaving quickly because I have to really sort out a lot of issues. Thank you.
Thank you. Have a nice
Thank you, Dr. Shanta.
Thank you, Dr. Shanta, ma'am.
Thanks a lot.
Thank you.
Thank you, ma'am. Good evening, ma'am.
Yeah, good evening.
To keep us inspiring.
Yeah, so let me continue from where I left off. So various forms and contexts of sexual violence are there, you know, and this wide range of violent acts can take place in different circumstances and settings. Most of you are aware of this or have seen some patient with rape within marriage or dating relationship, rape by strangers, systematic rape during armed conflict. I mean, we have seen a lot of it in Afghanistan and places like that. Unwanted sexual advances or sexual harassment, including demanding for sex in return for favors. You would see a lot of that happening in Bollywood. Although it is under the wraps, nobody talks about it in as much, and there's absolutely no conviction till date. Sexual abuse of mentally or physically disabled people, that is very common because they can't speak up. We have had cases in the hospital where ward boys have done that. And sexual abuse of children also is something which is very, very common. Seen. To continue, forced marriage or cohabitation, including marriage of children, denial of right use of your contraceptive to protect yourself against STDs, forced abortion, forced prostitution, violent acts against sexual integrity of a woman. All of these are forms and contexts of sexual violence, and the list seems to be endless. In the customary form of sexual violence, of child marriage, it is almost legalized or legitimized sexual form of sexual violence against women, which includes young children, particularly girls in many parts of the world, including our country. That happens. It is legal in many countries, is a form of sexual violence, but children who are involved obviously cannot give consent or withhold their consent, and they don't even know what is happening. And we have seen those kind of cases, especially in the Arab world, wherein they look for smaller or younger girls, and not just for sexual favors or marriage, but also as domestic help for them. So these are various things which are happening. We're all aware of it, and there are different consequences of it, which could be fatal and non-fatal consequences. Essentially, in terms of what is related to us, there could be pregnancy and gynecological related complications, STDs, mental health issues, we have talked about it earlier, suicidal behavior, social ostracization. All of this we have talked about in the earlier presentations, and also seen what possibly we can do to mitigate those effects. Fatal obviously would be thinking about or committing suicide, homicide. It could be AIDS related as well, something which could be fatal, because we do know while a patient for AIDS can survive for 20, 25, 30 years, but at the end of the day, it is something which cannot be overcome. Non-fatal, of course, which do not jeopardize the condition in terms of the fatality, but yes, it does affect the mental ability and stability of the concerned who has been affected. Unwanted pregnancy, infertility, sexual dysfunction, chronic pelvic pain, STDs, including HIV, obesity and anorexia, because you don't know what's happening, UTIs, GI disorders, gynecological pregnancy complication, migraines or other frequent headaches, fatigue, nausea, are all things which are related to the non-fatal outcomes. You have the rape trauma syndrome, social phobia, shock, increased use of substance or abuse, denial, you're in constant fear, there's confusion, why is it happening to me? Am I responsible for it? There's anxiety, oh, God knows what will happen to me next. Guilt, did I do something wrong? That's why I got into this, leading to a lot of depression, alienation. Essentially, you try to withdraw from social interactions and all of that. Eating disorders, of course, is also part of a non-fatal outcome, leading to obesity in many cases. What are the various approaches that one can take, and you can think about it? Essentially focusing on TIC, which is trauma-informed care approach, which probably is one of the tools which you can use, if not already using, to make sure you are in a better space, better informed to take care of the person who has been inflicted by such a situation. It involves thorough understanding of the neurological, biological, and psychological issues of the individual. Now, what is it that we are talking about in terms of TIC? Essentially looking at triaging the patient as a medical emergency is the first and foremost thing that we need to do. Immediate needs of a survivor of an assault, essentially from the triaging point of view, is to see that a medical or psychiatric evaluation is proposed or brought about for stabilization, activation of a community advocacy to the bedside, mandated reporting as directed by the state statutes, offering and conducting a safe examination, which is essentially if the survivor so desires to do so. Collaboration with law enforcement agencies, because they are the ones who are going to take the whole process forward to a logical conclusion. Pregnancy risk evaluation, care, and safe discharge planning are something which are in our domain, and therefore it needs to be looked into. Those providing medical and forensic care must always be prepared to provide testimony as either a fact or as an expert witness. And to that effect, documentation, a written documentation of everything that you do or practice has to be in place so that you are protected first, and then you're able to offer the similar kind of protection to the person who has come to you seeking the issue. What is TIC? Essentially, it rests on 5 pillars. The pillars are safety, trustworthiness, choice, collaboration, and empowerment. Let's look at each one of them now. Safety, essentially do not just barge into the door, knock on the door and ask the permission of the patient to enter the room. Meet the parents before they disrobe. It's their right to not do so. Ask the patient to disrobe only when necessary or only partially disrobe. Provide a clear, a clearly identifiable washroom or a clean washroom. Familiarize the person with the physical environment. Ask about comfort level with lighting, because sometimes in a dark or a less lit place, one may be more fearful, one may have more anxiety. Share control, show respect, and use a warm and compassionate manner to build a rapport, because that is important for the next step of trustworthiness and building that. Sometimes we think it's something which is obvious and therefore it should not be told. But in such cases, it is important that the entire procedural thing that the person will have to go through in the next couple of hours or next couple of days are clearly explained to the person so that they understand. And even if they are in no position to understand, whoever is a trustworthy person accompanying this individual also needs to understand and needs to be walked through it so that they can constantly keep hand-holding them. What and how long it's going to take. Ask the person what he or she wants, essentially, to take the process forward. Choice, essentially, is the choice of the person who has been affected by such a situation. Ask them if they can touch them every time. Ask before you invite an additional staff. Ask if you can close the door, because sometimes that can be intimidating. You're closing the door on the person, leading to further anxiety. Allow the person to decide where to sit in the room. Explain the rationale. I know it takes time, your valuable time, but it is important from the person's point of view that they understand that each procedure and what it feels like, and therefore appropriate modifications can be done so that the entire trauma itself is reduced. Obtain consent for each part of the exam before it is performed. That essentially contributes to the trustworthiness, contributes to your relating to them, constitutes towards the empathy that you're talking about in the earlier presentations. Collaborate. What are your top worries or concerns? Basically, getting to know from them. Share information. Encourage the person to make decisions about their treatment. And if they are not in a fit position to do so, cajole, talk one-on-one, empathize, to bring them out of their fold, to be able to take those difficult yet important decisions which are important for them. Empower. Ask, what has happened to you and not what is wrong with you, because there's nothing wrong with the person. It's just she happened to be or he happened to be in a wrong place at the wrong time, or somebody had different, ideas about that person. Never ask the question why, because it implies a fault. Why did you do this? Why did you not do that? Take time with the person so he or she feels genuinely heard. And listening is the key. Half of the communication is listening to what is being talked about. And ask the person what you should know before you begin the procedure. Ask if there's a way you can make the procedure easier for him. Ask if there is a way out, that you can make the person relax in a different position. Pay attention to body cues. Many times the survivor may not speak. They may be passive. And just because we are the service providers and the doctors in question, they may feel that we are authoritative, and therefore to that extent may not disclose what we require them to disclose for better treatment or better procedure handling of the case. We have talked about this in detail a bit of detail in the previous presentation, and in the next one, which is coming up, we will have a further detail about this. All of you may be aware of this, but it's important that we reiterate this entire thing once again, so that the documentation part that I spoke about during my conversation is indeed taken care of. So broadly, there are 7 elements here: the medical history, consensual sexual activity, assault-related medical history, sexual assault details, nature of the physical assault, post-assault activities, and the suspect information are the elements of a sexual assault history that needs to get into place. With that, registration and pre-test is all that you have done. That's the reason why you're here. And post-test and feedback will be shared to you in the chat box. Please click on the link and you will be directed to filling up the same. It takes just precisely 5 to 6 minutes for you to do so. With that, thank you very much for a patient listening, and over to you, Raki.
Thank you, Ajay sir. It was indeed more informative, I think. Are there any queries? Anybody would like to ask for?
There were some queries in the chat box. I don't know. I have missed them. If Kiran Mai has been keeping track, then we can go through them. Lata, link will be posted towards the end of it.
So there were some questions about POXO, so that were answered, I think, sir, and about one-stop crisis centers. That's it. Yeah.
Yeah. I think let's move on to the fag end, and at the end of the whole session, the link would be posted, and everybody needs to answer the post test, which is mandatory. Then only the certificates would be issued. Coming down to the last of the talks would be on examination of a survivor and collection of evidence, medical legal aspect of guidelines and protocols. And that would be taken by Dr. Anita ma'am. Ma'am, I think you would be able to share your screen this time. Ma'am, you're muted.
Please unmute yourself, Dr. Anita.
Ma'am, you need to yeah.
Can you see my screen now?
Yes, ma'am, but
Yes.
slideshow, enable editing, ma'am, first.
Click on enable editing, so it will allow you to.
Editing, then, yeah,
you're
great.
done.
See now?
Done. Yes,
Yeah.
ma'am.
Thank God. And thank you all of you for the patience. So I am the last speaker of the day. So maybe I'm the showstopper. And I'm very happy everybody is there to listen to this very, very important talk, which is examination of a survivor and collection of evidence. And because poor handling of cases that defeats fight against the evils. And although many culprits have been successfully prosecuted or thrown behind bars, but many of them, they go scot-free because of the lack of the evidence. So whole idea of investigating or examining properly for collecting proper evidence is to pin down the offender. So here we go. What is the role of a gynecologist? So the gynecologist is very important here because the important evidence of the crime which they are able to give that help judges understand physical and mental condition of the survivor, and also by using the reports to corroborate the survivor's story and enhance its credibility. And also it offers primary level counseling and treatment, and also referral for the physical and psychological sequelae. So doctors, the gynecologists are very important both for the evidence and also for the treatment part of the survivor that time. And now the medical examination, that includes, recording the complete history, detailed history, which is very important. And then the informed consent has to be taken. And after the consent, we have to do the documentation of the injury and evidence collection, nature of sexual violence, what is the time which has elapsed between the incident and the examination, and whether survivor has taken bath after the incident or has washed herself or her clothes after the incident. So we'll go into the details. So we have to remember the 25 points in this, that there are 25 things we have to do. First is the 11 things are the general instructions, which I'll be just dealing with. And then comes the informed consent, and then the marks of identification, which are very important. And after that comes the history. That includes the relevant medical history, the surgical history, and as Ajay sir was just telling, history of sexual violence, type of physical violence, and the emotional trauma. And then comes the examination part. And that includes the general physical examination, examination for the injuries, examination of the external genitalia, and ultimately the systemic examination. And then we have very important evidence collection and the sample collection. And after all this, we have to give our provisional medical opinion. And after the opinion, the treatment prescribed to the survivor. And after that, we have to document date and time of completion of examination. And after we get final reports, we have to give the final opinion. So as we just said, the general instructions are 11, where we have to write name of the hospital, the OPD number, the inpatient number, and name of the survivor, daughter of, wife of, or son of, wherever. And then address, and also age as reported. And if you have date of birth, we have to mention. And then mention sex, male, female, transgender, any, whatever it is. Then date and time of arrival in the hospital, that one. And then date and time of commencement of examination, which is very important. And then brought by whom, that person's name and signature must be there. And then the MLC number and the police station name from where she has been brought, and also whether she is conscious, coherent, oriented in time and person, and any physical, intellectual, or psychosocial disability. Because in that case, can we mute others? Can we mute others? Because in that case, we will be needing the help of interpreter or special educators, which will be needed, so that survivors who have special needs, like such as hearing or speech disability or language barriers, then or intellectual or psychosocial disability, so then they can help them. And now comes the informed consent and marks of identification. So in informed consent, or that has to be mentioned whether it was given or it was refused. So that is refusal also is mentioned here. So I, so and so name, daughter of, wife of, son of, hereby give my consent for medical examination. If she's given, then write yes. If not, then one we have to write no, that is N. Then for have given consent for medical legal examination. So she has to give consent for all these things: medical examination, medical legal examination, Then consent for sample collection for clinical and forensic examination. And also she has to give consent that she understands that as per law, the hospital is required to inform this to police, and this has been explained to me. And also she has to tell whether she wants the information to be revealed to police or not. So yes or no. And then I have understood the purpose and procedure of it, including the risk and benefit explained to me by my doctor, and my right to refuse the examination at any stage. And such refusal, including that my treatment will not be affected. Because even if she refuses, the medical treatment has to be given to her properly. And the above has been explained to me in her language or whichever language by a special educator, interpreter, sport person in case she had the difficulty. And if special educator or interpreter or sport person has been utilized, then that person's name and signature must be mentioned here, which is very, very important part of this document. And then marks of identification, and where we can see any scar or mole which has to be documented. And also the left thumb impression of the survivor must be taken and documented. And then comes the history, medical and surgical, which is relevant. So in case of girls, we have to ask her the onset of menarche, whether it has already started or not, yes or no. If started, then age of onset. And then we have to know the details of menstrual history, that what is the cycle length and what is the duration of a cycle. And then last menstrual period and menstruation at the time of incident, whether at the time of incident she was having periods or not, yes or no has to be mentioned. And also if there was menstruation at the time of examination, yes or no, so that things can be corroborated. And was the survivor pregnant at the time of incident, yes or no? And if yes, then what is the duration of pregnancy in weeks? And also if any contraception use was done, yes or no? And if yes, what method was used? And also we have to know in the history her vaccination status, whether she has been vaccinated or not for tetanus and also for hepatitis B. So all these have to be documented very clearly. And then the history of sexual violence, what was the time of incident, what was location, and what is the estimated duration? Is it 1 to 7 days, or it is between 1 week to 2 months, or it is 2 months, more than that, 6 months, or it is 6 months. And then episode, how many episodes she had to of violence, one or multiple, or chronic means if they were more than 6 months ago. And then number of assailants have to be mentioned, who assaulted her, and what were the names if she knew, and what was the sex of the assailants, and what was the approximate age of those assailants, and also if they were known to the survivor, then what was the relationship to the survivor, and also description of the incident in the words of the survivor, and narrator of the incident. If the survivor is not able to and we have the narrator's help, then we have to mention that who's this survivor, whether the information is given by the survivor or by the informant, and then what is the relationship of this informant to the survivor. And if required, if some extra information is there, we have to add extra page in this documentation. And then the type of physical violence used, if any. Now it can be hurting or burnt with, either with the hand or fist or blunt object, or with a sharp object, or biting or pinching or violent shaking or any other, or by kicking, or by pulling hair, or by banging head, or dragging. So we have to tick the relevant answers as described above. And then comes the emotional abuse. Now, emotional abuse could be in the form of insulting or cursing or violating or terrorizing the survivor, or using any restraints or restrictions, or using any threats, or the use of any weapons or any objects. And verbal threats like threatening of killing her or any other person she's interested in her, or related to her, or any use of photographs or blackmailing. And then luring by sweets, chocolates, drink, alcohol, drugs, money, job, if any. So these have to be mentioned, or if any other specific she mentions, that has to be documented. And then comes the history of alcohol or drug intoxication, and whether at the time of incident she was sleeping or she was unconscious. And if the survivor has left any marks of injuries on the assailants, that also maybe she has bitten the assailant, or she has hurt the done with the nails. So sometimes nail marks are also there. So that can be also documented. So then details regarding sexual violence. So over here, we have to know three words that we have to write yes. If that history is there, then you write Y. If there is no history, then no N. And if she doesn't know, then we have to write DNK. So was the penetration by penis or by the fingers or by any object or by other body parts? So we have to write accordingly. So as you can see here in the slide, penetration, which organ was involved? Whether it was genitalia, that is vagina or urethra, and urethra, and then whether it was anus or it was mouth. And then was it by penis or by the body part of self or of the assailant body part, or third part, that is finger, tongue, or any other, or it was penetrated by an object. And then we have to also see the emission of semen, whether it was there or not. So if it was there, then yes, it was not there. No, that has to be documented. And then details regarding sexual violence. Again, here also, if she says yes for that, then Y, and then if no, then you mention N, and if she does not know, then DNK. So forced masturbation of self by the survivor, or she was forced to do masturbation of of the assailant by the survivor, manipulation of genitals, any exhibitionism, that is the assailant or the perpetrator was displaying the genitals. Was there any ejaculation which occurred outside the body orifices, like vagina, outside vagina, or anus, mouth, or urethra? If yes, where on body? Was condom used? If yes, what is the status of condom? What is the lubricant used? If yes, describe the kind of lubricant. And if any object is used, if she could describe the object. So all these things have to be documented. And then after the crime, the post-incident details, they have to be mentioned, which are very, very important, because we have to mention whether she changed clothes after the incident, because so much evidence could be lost with that, whether she changed her undergarments, whether she cleaned or washed her clothes, or whether she cleaned her or washed her undergarments. Did she have a bath after the incident? Did she douche herself? Did she pass urine? Did she pass her stools? Did she rinse her mouth by brushing? Did she vomit? So all these things have to be mentioned, because that will direct us towards the evidence. And then history of any vaginal, anal, any urethral, any discharge prior to the act of sexual violence or after the act of sexual violence, or any history of painful urination, defecation, fissures, or pain in genitalia or other parts since the act of sexual violence, which has to be again documented to generate the proper evidence. And now comes the general physical examination, where the height in centimeters and weight in kilograms has to be taken, general build and whether she's thin or normal or obese, what is the gait, then all the vitals like pulse, blood pressure, temperature, respiratory rate, and the status of pupils, and any other disability or deformity that has to be documented. And then comes examination for injuries on the body. So they can range from complete absence of injuries, which many times happens, to grievous injuries, which might be present there. So then we have to know what kind of injuries they are, whether they are bruises or nail abrasions or teeth bites or cuts, lacerations, any fracture, any tenderness, boils or burns. And then which sides, whether on scalp or face or neck or shoulders or breast or wrists or forearms or medial aspects of upper arms or thighs and buttocks, which have to be documented. And then how do they look like? What is the size? What is the shape? The color, swelling, and any whether they are simple or what are their dimensions? All these things have to be documented. And then external genitalia, we have to record these findings and document them. This is very, very important slide. because we have to see labia majora, labia minora, the urethral meatus and vestibule, the fusae and the introitus, the perineum and the hymen. But something, mind it, this is very, very important, that per vaginal and per speculum examination should not be done. Per vaginal and per speculum examination should not be done unless it is required for detection of injuries or for medical treatment, very specifically. Because if they are required, then we have to record. Otherwise, if we are recording them, then we have to give the reasons why we had done the per speculum examination and per vaginal examination. And also, we can record anus and rectum. We can see, examine them. We can examine the oral cavity for any bleeding, any tear, any discharge, any edema, or any tenderness. But per vaginal examination or per specular examination should only be required, then only it should be done. It should be reserved. And then comes the last part of examination, which is systemic examination. So again, the central nervous system, the cardiovascular system, the respiratory system, and abdomen should be examined and documented. And now comes very important part, which is the evidence collection, the sample collection. To obtain, this is done to obtain the confirmation of the allegation. And then it is to establish the link between the victim and the scene, and also to establish the link between the victim and the assailant. So every contact leaves a trace. And if it is done very properly, we can always, the perpetrator can be booked for that. Otherwise, these perpetrators will go scot-free, and in future also such people will go on and these violences will keep on happening. So the evidence collection, always maintain the chain of evidence, identify the specimen and label the specimen and sign the label and record them and record them all properly. And hospital, so the sample collection and investigations are done at the hospital laboratory, clinical laboratory, and also at other samples for the central and state forensic laboratory. So the tests which are done at the hospital laboratory or the clinical laboratory are blood for HIV, VDRL, hepatitis B, hepatitis C, urine test for pregnancy, ultrasound for pregnancy or any internal injury, and X-ray for injury. And for the forensic laboratory, state forensic laboratory tests are debris collection paper, clothing evidence where available, which are to be packed in separate bags after air drying, so that whatever material we have, they are not disintegrated. So the sample collection is swabs from stains on the body like blood, serum, foreign material. The scalp hair, very important, 10 to 15 strands minimum should be taken. Head hair combing and nail scrapings, both hands separately. Oral swab, blood for grouping, testing for drugs or alcohol, then blood for DNA analysis. Then urine for drug testing, any other like tampon or sanitary napkin or condoms. And if these are not collected, then reasons for not collecting, they have to be documented. Genital and anal evidence, each sample to be packed, then sealed, and then labeled separately to be placed in a bag. So matted pubic hair combing, if they are shaved, then it has to be mentioned that pubic hair are shaved. Cutting of pubic hair, again mention if shaved. 2 vulval swabs, 1 for semen and for DNA. 2 vaginal swabs, 1 for semen and DNA. 2 anal swabs, again for semen and DNA. And vaginal smear, which should be air dried for semen examination. And a urethral swab, samples, they should be preserved as directed till handed over to police along with the duly attested. So if not collected, the reasons for not collecting. So these samples are very, very important, and they have to be preserved till they are handed over to the police. So provisional medical opinion. So after all these tests, the provisional medical opinion has to be documented by writing, as seen in the slide, that I have examined name of the survivor, male, female, or other, so much age, and what type of sexual violence and circumstances, and how many number of hours after the incident, and after having bathed or douched, a number of times. All these things have to be mentioned. And then my findings are as follows, and samples collected for forensic laboratory awaiting reports, and samples collected for hospital laboratory, clinical findings, and additional observations, they have to be documented. And then after that documentation, the treatment prescribed. So it has to be mentioned yes, no, or any other comments. Like if treatment for sexually transmitted infection prevention has been given, it has to be documented. Any emergency contraception treatment given, any wound treatment, tetanus prophylaxis, whether given or not, hepatitis B vaccination given or not, then post-exposure prophylaxis for HIV, counseling done, and any other specific thing, they have to be mentioned and documented. And then after that comes date and time of completion of examination, and this report contains so many number of sheets and so many number of envelopes, and then the examining doctor has to sign, and the name of the examining doctor has to be written, and a stamp has to be put over there. And then comes the final opinion. So after receiving the lab reports in the following mentioned formats, opinion regarding sexual assault of the survivor to be given in a case of sexual assault or rape. So there is evidence of, there are different, these are about 11. There is evidence of recent sexual intercourse has to be mentioned if there were recent injuries to the genitalia and other parts of the body, and fresh spermatozoa could be recovered from the vagina. And it could be mentioned remote sexual intercourse if partially healed injuries were there and there were non-motile spermatozoa present in the vagina. And then recent penetration if local recent injuries to the external genitalia and spermatozoa are recovered, not recovered, because this can happen in case a patient is, the male is vasectomized, or it was a condom was used, or some finger dildo or some other object was used for penetration. And then there is evidence of remote penetration when locally or partially healed injuries to genitals and no spermatozoa are recovered. Fifth is there is evidence of recent sexual intercourse. Again, recent injuries, bite marks on the breast, neck, nipples, thighs, and again, evidence of remote, same way as we mentioned in the penetration, because in report the partially healed injuries or bites on the cheek, etc. would be there. And then there is no evidence of vaginal penetration, but possibility cannot be ruled out when there are no injuries and no spermatozoa recovered from the vagina. Then evidence of recent oral anal intercourse when recent injuries are noted and motile spermatozoa recovered. So whenever it's recent, we will find motile spermatozoa, and when it is report, we will find non-motile spermatozoa. And if there is penetration, then usually we don't find the spermatozoa. And if there's no evidence of oral or anal penetration, but possibility cannot be ruled, that can be mentioned when there are no injuries and no spermatozoa are recovered. So opinions regarding sexual assault of survivor to be given in a case of sexual assault. So findings in support of the above opinion, taking into account the history, the clinical examination, findings and laboratory reports of the clinical laboratory, as well as the forensic identification marks described above, and so many, after so many hours or days of the incident of sexual violence, I am of the opinion that, as we mentioned in the above 11 clause. So that opinion has to be documented, and after that the signature of the examining doctor, name of the examining doctor, and place and the seal, which is very important. And along with that, the copy of the entire medical report must be given to the survivor or the victim free of cost immediately. So to summarize, the informed consent is a must. After that, this is very important that per vaginum examination or the two-finger test is not to be done, and the comments on the hymen or the size of vagina, etc. are not to be commented. And only in those cases where it is dire necessary to document the injuries or other issues, only then the per speculum or per vaginal examination should be done, and injury documentation should be done, sample collection to be done, and after that the final opinion. So following are the components of a comprehensive healthcare response to sexual violence, and they must be carried out in all cases and documented well. So as we say on the left, consent, And then the first aid. After that, take the history and do the examination. And examination includes age estimation, physical, dental, radiological. And after that, we have evidence collection. And evidence collection has to be documented and then sealed, and the pack should be dry. And then after that, they should be handed over to police. And after that comes the treatment. And treatment is for injuries, for the sexually transmitted infections, test them and treat them, and give prophylaxis and do HIV test and post-exposure prophylaxis, emergency contraception, urinary pregnancy test if applicable, do counseling and give information and referral to other services. And then after treatment, you discharge the patient and then do a follow-up. So advise that. So that is complete part of this. And then we have the sexual assault forensic examination kit. Annexure is there, where we have the fixtures, we have the equipment, the drugs and commodities, and the documentation. So the fixtures, we need examination table, light, and preferably fixed, curtains, table, chair, wash basin, ruler. And for equipment, we need torch and tweezers and scissors, nail cutter, comb, measuring tape, calipers. And the drugs for prophylaxis, as we just mentioned, as we need them for treatment of sexually transmitted infections as per our country protocol, syndromic case management, antibiotics, antiretroviral drugs for post-exposure prophylaxis of HIV as per protocol, case specific, then emergency contraception, analgesics, tetanus, prophylaxis, pregnancy test kits, and magnifying glass. And the documentation for the consent forms, the reporting forms, and the receipts for the evidence. So again, the annexure for our evidence. So we evidence collection, we need all these things over here: sterile gauze swabs and 5x5 and swab containers for transporting swabs, microscope slides, vacutainers, sterile urine specimen containers, sheets of papers, paper bags, plastic specimen bags, spatula, sterile surgical gloves, mask, cleaning materials, antiseptic solution, perineal sheet, gown, cloth, or sheet to cover the victim during the examination, sanitary napkins, speculum, proctoscope, inoscope, tunicate, sterile water, normal saline, and scales for height measurement, and stationery. Then sterile foam tipped applicators, shoe cover, cap, filter paper, sterile swab sticks, and phosphate buffered saline. These are all again used so that the evidence is not hampered and we are not destroying the cells. So all these have to be used. The hand wash, the cartons, cotton roll, and the red sealing wax, because again the evidence has to be sealed. Then bandage gauze, plaster big size, envelopes with outer and inner cotton for collection of different evidences, syringes and needles, and FDA cards and pouch. Again, they are for collecting the evidence, the blood samples, etc. So these are the ultimately things we required for the examination. So we have a lot of acknowledgement and references, and we are really thankful to Obgyn Gynae Society of Hyderabad, of course, the society which belongs to Dr. Shantha Kumari, our president, and to the police department of Telangana Police, and of course, our Ministry of Health and Family Welfare, Government of India. Thank you so much. And I think I must thank Mr. Ajay, sir, for the whole guidance. Thank you so much, sir. So again, the same slide for everybody after every lecture: registration, pre-test, and then post-test and feedback. Thank you very much.
Thank you, Dr. Anita. It was again a lucid talk, crisp, and I hope everyone would be benefited with it. And there would be a link which would be put up in the chat box. Kindly, please do complete your post-test, and the link would be shared. And if you are not completing it immediately now, then we will not be able to get the certificates. And it is in the auto mode what it runs. And even if we send the mails 10 times to the Foxy office or the UNICEF, it will not work. Yes, Dr. Neelam, is there anything? Dr. Neelam, ma'am. You can unmute yourself, ma'am.
Yeah. Thank you.
Yeah.
Wonderful and so much to learn.
I'm just saying that it was a wonderful session and learned so much. And the last session was very exhaustive. My only doubt, self-doubt, and every time I attend this session or every time I do a self-reading on assessment of the survivor, I ask myself whether I am going to be able to do this, whether I have the capacity, because my training is not enough. And not having had exposures, naturally, you don't have patients coming to you so frequently or that you are able to do it comfortably every time. Now, and maybe others are also going through the same feeling that if I have a patient who comes to me, what am I supposed to do? So I did ask the civil surgeon of Ludhiana once about this because I had this doubt. And he told me that you do not have to do anything, just send the survivor to the one-stop crisis center. And I asked him again in detail, would any action be taken against me if I did that, not immediately examined and sent that survivor? So the answer I got was that no, ma'am, it will not be done. You just inform somebody officially and send the person there and everything will be taken care of, because you might not have the whole equipment and you might not be equipped with knowledge enough to be able to do it. I just want to know, is that the correct approach?
May I speak? Depends on the state policy, madam. Maybe Ludhiana has made it like through a centralized one-stop crisis center. Maybe you are advised to route the survivors to that place. But as such, a gynecologist is expected to know these procedures, especially the examination of the sexual assault survivor.
Yeah.
Mostly government college receives this and we learn it like in a practical way, no, though not in a such an exhaustive and correct way. We keep
Exactly.
going and going to the courts and giving witnesses, and sometimes we are, and sometimes they do say that you are being so non-committal, the offenders go scot-free. But this guideline was developed by the government of Telangana along with the police department and OGSH, and Dr. Malti is one of the important resource persons. That booklet I am trying to share in the chat box, the PDF. But the assault survivor comes to us uh, because we are I mean supposed to examine them. We cannot say that we don't know. That is one thing, especially the public and also the private. Like the woman comes to you, you are the private consultant over there, but you cannot redirect her to here and there. That may lead to a delay of the evidence being lost and the care being delayed and all. So it is better we are aware, and also the resource where it is available. Government guidelines, Minister of Health and Family Welfare guidelines are there, and this our state government's guideline has come in a booklet, and this is what we have made it into slides. We have kind of condensed it.
Totally agree, Dr. Kiranmay. It is just that, like I said, having studied all this procedure, the testing, how to carry out the test, and the kit, it's not difficult. You can buy a kit and keep one of them. All the label samples which needs to be taken, and of course we know how to do an examination. It is just that since it is not something which happens every day, that even thinking of such a thing in the private sector, and I think I speak for a lot of people who have this thought in their mind or a fear in their mind that if a patient comes to me, then a survivor comes to me, when will I be able to do justice to that? So I really thought that I needed to ask this question.
Yes, ma'am.
Thank you
But as
for
you said, the one-stop crisis centers can have a central streamlining, and they can. But here the issue is the medical officers in the one-stop crisis centers are not many. That also adds to the load of I don't know if how it is in other states. Ajay sir?
Add over here, 1 minute, 1 minute.
Hello.
And to add to all of this, while you may have in your state or your city a center which is willing to take on the responsibility, not every center or a state has it. So to that extent, knowing what is to be done, which you already know, but in a more systematic and a logical way, which is required by the law, may be a good idea to have. And all of these, that entire booklet has been consolidated into precisely 35 slides. So even having ready access to the 35 slides at any given point in time is going to be helpful for you in case you do end up or have to do a complete examination. So I hope that helps and answers your question.
One suggestion here. One suggestion. For so many times that we use, these chart we paste on the walls of our clinic, or we have them under the tables. There is a laminated one-sheet detail which describes all this. Is something like that available? Because if it's up on the wall, then you know that this is
right now it is not available, Neelam. Having said that, we could always create one from the slides which are already there. Something to think about, and we'll see how best we can afford.
Yes, a flow chart of this is how to go, and which might help. Thank you so much, Mr. Ajay, and thank you, Dr. Kiran.
Neelam, I would like to I'm also the additional chief civil surgeon right now.
Oh.
Additional surgeon. So what the civil surgeon told you, I don't think that's correct. Because wherever the patient comes, the initial examination you have to do, then only you can refer the patient to any other place. That's what we do.
So, and so the collection of samples and everything will have to be done then. If the initial examination has to be done, then the whole thing.
Yeah, then you can send the sample to the higher centers.
Yeah.
You need not examine there only, but you have to do the first examination, and you'll have to be the witness. Today also, I had given 2 witnesses for this similar case, rape cases. So that is one thing we have to face. We cannot not fly away from it. And
thank you so much.
Monica, you have something to say?
Yeah, hi. Wonderful session. I must congratulate you, Mr. Ajay and Dr. Kiran. Just adding over to what Dr. Neelam said, because I am also in charge of one-stop center in Safdarjung Hospital. We've always maintained this, that in accordance to the Government of India guidelines, whether private or government, nobody can actually say no to to seeing a survivor. So whatever initial examination and reporting has to be done, that is mandatory at your part if the survivor happens to report to you first. And then for the want of any for the want of any facilities which may not be there at your center, that you can approach your nearest referral center, or maybe the one-stop center nearest to you. But you cannot say that a survivor came to me, and for the want of not
Yeah, we are losing you, Monica.
what was to be done, I referred that patient.
Yeah.
That is not allowed under the laws which are prevalent now. Okay. So I just wanted to add that. Thank you.
Thank you.
Yeah, Dr. Achla is also there with us. Madam is there. Of their AOGD meeting, she's here. Dr. Achla, you would like to say something?
No, I mean, I will just same thing I was about to say, which Monica said, that we cannot refuse. You have to see the patient for whatever you can do, you have to do. And they're very good, I think everybody who is running a clinic or even a small clinic should have those booklets which we have, which gives a detail of what you have to do, what samples to be collected, which is not very difficult. It can be done anywhere, So I think those which are available by Government of India also, which should be there with everybody. Whosoever is practicing gynae or has a nursing home should have those booklets in which all the details are there, what samples. It's not necessary that all samples have to be taken, but whatever required, wherever required, that should be available. Everybody should know that they have to.
Achla ma'am, it's a 100-page booklet, Government of India, and the state government of Telangana made it 50 pages.
No.
But
I don't mean the booklet.
No. What the slides?
I mean the booklet in which.
Yes. We have taken from those 2 guidelines and.
But we have to have.
Yeah. Please go on.
Yeah, I don't mean the 100-page booklet. What I mean is for taking the samples, we have few pages, not 100 pages. For taking the samples.
Just a summary of it, main points. Ideally, they wanted to be kept in all the.
That is what we have put up in our slides, Rakhi.
Yeah.
Okay, so that's that for the evening, and we have posted the post-test link already in the chat box. Vanaja, it's up there. I posted it twice. So click on the link and you'll be taken to the post-test section. Now, what is our expectation from each one of you before you leave? We will be calling upon each one of you to volunteer to conduct similar sessions in your society or any other society who may be doing this program. We are expecting between now and December 2022, a lot of societies will be taking up this program in their respective societies for their members. So there will be an Excel sheet which will be sent to you from time to time. Please add your name and email to it in case you want to take 2 or 3 sessions like we have done today. A video recording of this will be sent to all of you so that you can refer to this going forward. And if there are no further questions, I think with the permission of all the faculty, we can call this session to a close with a huge round of applause to all the faculty, and especially Amita, because you had to do the last, over last batsman, and you had to score a 6 to go, win the match for India. And I think you've done that very, very successfully. Yeah. All the very best to each one of you.
Hello. This is Dr. Asha Jain. I'm speaking. I could not see the link in the chat box.
Okay, let me post
for
it.
the exam.
It's posted again just now.
Thanks, Jay.
Yeah. Just
It's there at 6:30, madam. Just move up.
Okay. Yeah. There are so many messages.
Yeah, it was go move up to 6:30. It is there.
30,
Yeah.
35.
Got it.
35.
Got it.
Yes, got it.
Great.
Chalo.
And my request is after submission.
Booklet, I mean, those who want to download can download.
Okay.
Sheet.
And a humble request. So yeah, Kiran Mai has posted the booklet here, which is a compressed version for your ready reference. And my humble request is, as soon as you get out of the meeting, after submission, do not send us a mail. Where is my certificate?
आप आओगे क्या? हाँ ठीक है ना, आप एक सेकंड इधर आओगे क्या?
Dr. Asha,
So,
Yeah. Is that good?
yes.
Call the meeting to a close now.
Yes, sir. Thank you.
Thank you
taking a
so much.
photograph, sir. Taking one photograph.
Okay. Okay.
So exhaustive.
All the people who are here, you can open your videos. So
Yeah,
that
please, can you put on your videos on?
people can also take a good photo. I am trying to take one.
Freeman will take. Hello, Dr. Vidhu.
Yeah.
Is the photo done?
Yes, from my side done. Your IT people, I don't know.
Great.
Thank you. Yes, done, sir. Done. Thank you so much.
Thank you so much, everyone. Have a wonderful evening and a great weekend to follow.
Yes. Tomorrow is the New Year day for most of India, I think.
Oh, okay. So greetings to each one of you.
Yes, Happy New Year. Happy New Year. Happy New Year. Yeah. It's nice.
Take care, all of you.
Okay.
Bye-bye.
Bye-bye.
See you soon, sir. Bye.
See you. Bye-bye.
Thanks, Mr. Jay.
Thank you.
Thank you, sir. Bye-bye, sir.
Bye. Bye-bye. Thank you, Anita.